it is shut down of the technical issue, then it's close it.
Yeah, Zoom. I think it does that sometimes.
Yes. I'm sorry, this is my time now to
Yes,
be sharing the content.
Yeah, it's I've just said that you're doing your presentation. So the floor is yours.
Okay, thank you.
Thank you very much.
Assalamu alaikum. Good morning for all and good afternoon for some. My name is Roa Aman from Saudi Arabia. I'm bachelor degree nurses, master degree of healthcare management. We are a group of researcher association in Eastern province. We do this study about assess the causes of absenteeism and the factor affecting it among nurses working in Eastern regions in Saudi Arabia. I will be talking about the introduction, significance of this study, statement of the purpose, specific, objective, research question, and research methodology, setting, tool, conclusion, and the reference. You know, the largest group of healthcare providers in the country are nurses. They deliver the high percentage of healthcare, despite the fact that being the largest group of health provider, the nursing workforce has experienced an acute shortage affecting the delivery of healthcare. Saudi Arabia is challenged also with a chronic shortage of qualified Saudi nurses, accompanied by a high rate of absenteeism due to uncertain causes. Significant of this study, the research aimed to assess the causes of absenteeism among nurses working in general hospital and to compare with other nurses working in psychiatric hospital in the Eastern region in Saudi Arabia. Our research question was, what are the causes of absenteeism among nurses working in the hospital? The literature review was the line with the strategies of a transformation in health sector and the mission to improve working environment, which has significant impact on improving the challenge. Faced the nurse, when which is the low ratio of nurses in practical to the increases population level. This Ministry of Health, the healthcare service are complex, required higher degree of knowledge and well-coordination situation to deliver a well-organized and effective healthcare system guideline. Staff nurse shortage has been a significant problem in the workplace. Absenteeism can be considered as an important indication regarding the performance of health workers, as well as a good measurement of the psychological and physiological health of health workers. To clarify the meaning of absenteeism, it doesn't only mean as a non-work attendance as a schedule, but also include an unscheduled shift part-time absence. Moreover, it doesn't expand as arrive late, leave early, and take long off day, more than duty schedule in their work. However, absenteeism is usually measured by the frequent or duration of working days lost. Unfortunately, absenteeism is a dilemma that nurse manager has to deal with everyday routine. In general, nurse frequent absenteeism take into consideration as a negative expression and insufficient productively. As a result, absenteeism has significant effect not only in the quality of patient care, but also impact nurses' value and behaviors. According to a study, the absenteeism has effect in the psychological and professional well-being of nurses. In addition, it could increase the psychological stress in the nurses remaining in the duty and increase the workload wherever given extra tasks to finish. It may also increase the risk of medication error and leads to unhealthy working environment. Nurses working in good environment area with safety, less mental and physical stress, and working better than other area with less absenteeism. According to the statistics of the Prince Saud bin Jaloui Hospital and Al Ahsa Hospital, in year 2018, it was found that absence rate up to 79% among nurses. Although there are quite many studies about nurses in Saudi Arabia, they are not attention about the absenteeism causes and the factor affecting it among nurses in hospital in Eastern region in Saudi Arabia. For this reason, the current study will be carried out in General Hospital in Irada Complex for Mental Health Eastern region, this hospital in Dammam, and the investigation causes absenteeism among nurses absenteeism and take in consideration many key factors, example, culture different, work environment, year of experience, and job specification. And this is study done by in the Al Ahsa and Dammam and Qatif and Dammam. It will be mental health and general health hospitals in Eastern, all in Eastern province. Method procedure, research design, a descriptive, exploratory, quantitative study design will be used in this study. This study will be carried out the male and female psychiatric unit and rehabilitation in Irada complex for mental health, Dammam in Saudi Arabia. Each has capacity have 70 beds, the total number of nurses 429 in the complex. And also the emergency room and female patient medical surgical wards in Prince Saud Jaloui Hospital and Al Ahsa. Hospital capacity 250 and to 220 beds. Each unit has capacity of 30 beds. The total number of nurses 376. Between the males are 35 and the number of female nurses 173 in both sections. The number of Arabic speaker nurses around 57 of the total number. Also in the Qatif Central Hospital at the emergency room, female and male, inpatient surgical and medical wards, hospital capacity general 329 beds, total number of nurses equal 453. Moreover, the Dammam Medical Tower Hospital also capacity general 423 beds. Total number of nurses equal 1,287 nurses. Subject convenient sample was used. All nurse staff were available in the mentioned set during the period data collected, who were willing to practice in research include. Participate in the research was included. The researcher moved between settings as much possible. Was used to this study, the practice and environment skill, structure interview, socio-demographic data, including gender, age, material status, distance from work, and year of experience. The method was ethical approval was obtained from ethical committee from the Ministry of Health. Official written permission to conduct the study was obtained from the responsible authorized. Participants were informed about the aim of this study to ensure about confidence and privacy of the content and the result. The researcher handled the questionnaire to the staff online form. The researcher were considered time planning in order to permit at least 30 minutes for the question to be completed. Statistical analysis to collect the data was analyzed and tabulated using SPSS for Windows. A proprietary statistical test was used. Statistical significance was considered at p-value less than equal 0.05. The result of 350 participants, 257 completed the question. Constating response rate of 73%. The majority participants were women, Saudi merit standard deviation equal 1.033. Regarding their education, most participated had a diploma degree with equal 1.17. Regarding for work experience between less than 1 year and more than 20 years, and mean standards deviation work experience of the participant was 2.442. It will be shown in the table. And on another hand, 104 nurses work more than 5 kilometers to 20 kilometers, whereas the mean was 2.27. There was a statistically significant equal 0.001 between the participant and the number of days of absence in the last 3 months. There was significant population equal 0.992 merit and absenteeism. In addition, nationality nurses was no statistically significant in the overall study, be equal 0.532. One way ANOVA was conducted determined the difference between the participants in different departments. Pediatric intensive care unit showed the highest score for absenteeism, mean equal 2.60, SD equal 1.035, while outpatient showed the lowest score, mean equal 2.56, SD equal 1.014. There was significant difference in absenteeism between Prince Saud bin Jloui, mean equal 2.94, SD equal 0.885, and Qatif Central Hospital, the mean was 2.34, equal 1.073. A total of 257 participants joined this study. Present the demographic responded where majority of respond 79% female and 20% male. 82% Saudi, 70% none. Of representatives, 24.7 married and 21 single. Divorce 3.5, we do 8%. Most of the responded 61.9 diploma, 34 bachelor degree, and 1.9% master and PhD. 40.5 than 5 kilometers to 20 kilometers, and 70% less than 5 kilometers, 23% more than 20 kilometers to 50 kilometers, and 7% more than 150 to 100 kilometers. 15% more than 100 kilometers to 100 kilometers, and 14% more than 200 kilometers. Majority of responded 32.7 of Qatif Central Hospital, 31.5 Prince Saud bin Jloui Hospital, and 18.7 Irada Complex for Mental Health, and 17.1 in Dammam Medical Hospital. Limitation study. This study had limitation related to the number of participants, 257, and this finding are relevant to sample only. Sorry. In this study, duration of work experience, 8.9% less than 1 year, 26.5% of respond, 1 to 5 years, 29% experience, and to 6 to 10 years and to less than 20. Analysis showed absent in the past 3 months and what the causes among the response of absenteeism are. Majority is having health problem, personal and family problem, 60% non-cooperative from supervisor working in different without weekend off. In addition, no supportive and appreciated from head of the factor influencing absenteeism among nursing staff in the hospital. Majority of them is presents health problem. In addition, there is represent where extremely dissatisfied in the general relationship in the unit, resolving disagreement, conflict, and work motivation. Stress develop way involve nurses' awareness and involvement of the staff toward achieving on the specific goal in the unit. In conclusion, work in the administrative time. The majority of the respondents answered they have never been absent for months, thus considering their level specification and commitment skill. Developing motivation strategy. Employees feel that their work is value and creating flexibility by providing a flex time, because nowadays employees value personal time, especially for family needs. Motivation, initiate the staff will involve them in all strategic plan and goal of the hospital, administrative hospital. The recommendation proper communication in the form of regular meeting between qualified staff members, lecture, education program, aware of the problem experienced by the head qualified to improve the relationship. All administrative to be good relationship with the staff and cooperative with them situation. Oh, thank you. Just before that, challenge are what make life interesting, and overcoming them is what make life meaningful. Thank you for all for your listening.
Oh, thank you very much for sharing that. Has anyone got any questions? I just wanted to say that I think it was a good presentation, and I think it's very important to highlight the impact that mental health and other factors that affect the nurses and how it can cause high levels of absence and whatnot. And I think it's good they did a systematic review around that and got the different factors that were involved, which I thought was quite interesting.
Yes. Yeah. Thank you for you also and for your listening, and must be motivation our nurses and good relationship from the administrative and the head department supervisor with our nurses and everywhere. This is the time for them to be also care of them, to be giving more, because all hospital I think need the nurses to be in good healthy and good mentality and more motivation to good care for others.
Definitely, and they're all doing a great job.
Thank you.
Anyone got any questions? If anyone does have any questions, just put them in the box and hopefully we can answer them later. So, I guess it's time for our next speaker. So our next speaker
Hello.
is...
Hi.
Hello there.
Hi.
How are you today?
Good. How's things there?
Yeah, no, everything's all good here. Yes, we're just in the process of finishing our first speech. Did you see it?
Thank you. So can you share the presentation? So to start, yeah. Thank you very
Yes,
much.
look, I just want to say the next person is Miss Jumana El Abed. Is that right?
Yeah.
Thank you very much. From the UAE, and she is a senior analyst in quality division and the executive assistant of Healthcare Quality Advisory Committee at the Department of Health, the regulative body of the healthcare sector in the Emirate of Abu Dhabi. She is a mathematician with master's degree in quality management and a certified Six Sigma black belt, professional with more than 15 years of experience in the healthcare sector, and holds a patent in healthcare quality field. I'm passing her the stage to deliver the keynote speech. It's all yours.
Thank you. Hi from the other side of the world. So good afternoon and good morning as well. So today we are going to start, but I can't see the presentation. So could you share the screen, please?
Sharing the screen.
Yes, to see the presentation. So my name is Jumana Al Abed. I'm the senior analyst in quality monitoring department in the Department of Health. Abu Dhabi is the regulative body of the healthcare sector in the Emirate of Abu Dhabi, and it's ensured the excellence in the healthcare for the community by monitoring the health status of the population. So in DOH, it defines the strategy for the health system, monitors and analyzing the health status of the population and performance of the system. In addition to that, DOH shapes the regulatory framework for the health system, inspects against the regulations, enforces standards, and encouraging the adoption of 4D class best practices and performance targets by all health care services providers in the Emirate. Also, the DOH drives the program to increase the awareness and adoption of health living standards among the residents of the Emirate of Abu Dhabi, in addition to regulating the scope of services and reimbursement the rates of the health system in the Emirate of Abu Dhabi. So okay, we are going to present, and if you do have any question, please write it down in the message, and also I'm going to have poll questions, and you can answer it also in the message box. So next, please. Yeah. Department of Health Strategy identify 12 strategic objectives across 6 themes, as we can see here: the public health, the quality, the information, the digital health and in research accesses, finance, and also the governance and capabilities. So for the public health, we are aimed to prevent and control diseases and other public health threats, as we can see what we have seen in the last year and this year as well for the COVID-19 pandemic. For the quality, we're aiming and we are achieving the high quality of outcomes across the continuity of care, and also to increase the healthcare outcomes. In addition to that, also to increase the public confidence in the healthcare services. For the digital health and researches, we continuously monitoring and evaluate and adapting the cutting-edge digital health technologies, and also for foster innovation and research in the healthcare sector in Abu Dhabi, as we have a research center that encouraging all the researchers to have the research and projects to be published for the Emirate of Abu Dhabi. Also, we do have the access to ensure the optimal availability of the healthcare in Abu Dhabi, and also to ensure the access to health services at the right time. So this is the access, the aspects of the quality as well. So for the finance theme, we are aiming to achieve the value of money throughout the healthcare systems, and also to ensure the long-term finance sustainability of the healthcare in Abu Dhabi. For the last one, the governance and capability, we are ensuring the robust government and coordination for the healthcare sector, and also to build the effective and efficient processes and capabilities within the Department of Health. Next, please. Okay. So to ensure the sustainability of the quality and the quality of care for the residents of Abu Dhabi, we have created a framework that based on the 5 elements that resulted in high impact of behavioral change management in the healthcare quality. The framework assists to the objectives of the framework is to assess and guide the development of quality indicators, and also to metrics for each dimension of the healthcare framework, and for the methodologies to measure the accurate data, and also to have the mechanism to ensure the compliance of the healthcare outcomes with the objectives of the healthcare sector. Finally, also to cross-cutting enablers to enhance the system quality and ensure sustainability. We do have these domains that are the framework, metrics, validation. We are going to explain it in seconds now. So we'll start with the first one, the design the framework. Next, please. So by designing the framework to come up from the current status to the desired state. So by defining the aspirations and objectives of the framework that are the promoting continual improvement in the safety and equality, and also to enhance the patient experience and public trust, as well as to promote the accountability and transparency. We have also in the framework studying the capabilities of the healthcare providers to define also the stakeholders and partners, and also to changing the mindset to create the quality culture and improve the quality index among all the hospitals. Next. So for putting, this is the metric dimensions, we have putting the right metrics together by exploring the healthcare models globally, as we have consultation and collaboration with international organizations such as the CQC, IHI, and other organizations, and also to define the domains and measure for each aspects, and define the resources and engage the experts in the field to get their knowledge and experience to improve the quality culture here in Abu Dhabi, and also setting the target by looking to the benchmark international to compare the results between each and try to achieve the target also. We can see here the framework. This is the quality framework that calling Jawda in Abu Dhabi, that covers all the aspects of the healthcare equality, which is the unique system that have all of these aspects. Next. Okay, so the other dimension of the framework that is measuring and validation, it's by building the tools and methodologies to collect the data from the different resources. What we are doing here in the Department of Health, we have the online submission by providers on a quarterly basis, and after we getting their performance, we validate the results, and we have also our resources to check their validity of the submission, and we have also the audit team to check the validity and ensure they have capturing all the data and indicators to give the correct picture of the hospital in regarding the quality culture there. So also we are putting the methodologies to determine the performance within each dimension and for an overall quality performance. Also, we are utilizing the advanced analytics tool and benchmarking, as I have mentioned before. Next, please. This is the compliance accountability as well. This is dimensions. Again, we have the benchmark to see what we are going to check. If there is any weaknesses with the hospitals or anything, we have the accountability policy and standards to check on their hospitals and improve, trying to work with them to improve their performance. Next. Okay, the intervention, the last dimensions, we can see that the intervention is the last domain that is expanding the measure and KPIs, and also to expand the framework to different medical services, and to have the automation and AI, and also to have a framework that is being reviewed by the international organization, such as, again, the CQC, IHI, and other organizations we are working on to have the collaboration between the Department of Health and these organizations. So let me have a question for you, and you can answer it in the message box. So next, please. Okay, from your experience. Next, please. Okay, so before going to Muasher, what is the biggest challenges have you faced? This is from your experience. Have you faced, and you may face, when applying the quality improvement initiative? Okay, I can't see the answers. Okay, compliance from the senior management. Okay. Any other question? No continuity and process? What about the data validity? Yes, excellent. Sustainability of the outcomes, that's very good. Okay, and also we have the resistant and behavioral culture, since we have started in 2014 for JODA program. Okay, so we have, since we start the JODA program in 2014, we have resistance and also difficulty of understanding what we are aiming to have. And now after 6 years, we have sustained and we improve. We have great achievement for this program. Which allow us to extend and expand the JODA program to be Muasher. Muasher is innovative and comprehensive quality of care that is launched in 2018. It's again following to the success of the JODA program that introduced in 2014. We have worked hard to assist and enhance the program to ensure the sustainability, to continuously improve the quality of care, and also enhancing the patient experience for all our residents of Abu Dhabi. And also over the past year, we have it's been developed through engaging the public and the internal and external experts to have this Muasher project. Muasher covers all the aspects of equality, that including the patient safety, effectiveness, timeliness of care, patient centricity and satisfaction, as well as the sustainability and accountability. So for Muasher, we do have the objective. Objective is to improving the quality of care of the healthcare sector, safety standards, and also to enhance the patient experience, and finally to enhance the transparency and accountability. So next, we do have Yes, we do have the 9 dimensions of the quality care of the dimensions that combine together to get one composite score for each of the hospitals and to give the number of diamonds based on these scores of the 9 dimensions. We can see that the clinical care outcomes that is taking the highest weight compared to all other dimensions. We do have the patient voice, quality assurance certificate, health regulations assurance, patient happiness, staff happiness, safe workplace, research and innovation, and finally the correct claims. Next, please. So now we are going to describe these dimensions. For the correct claims, what we are doing is it's more than 32 clinical indicators to check the effectiveness of care and the complication in the hospitals, to check the weaknesses, areas, and also we do have the readmission indicators, the mortality indicator, and other indicators. So these are combined together in one score, and we have also the risk adjusted to come up with the score and to make fair for everybody, like the case mix index and the patient volume as well. So we have also the validation that is taking a percentage of this factor. The patient voice, that is the clinical complaints that coming to the Department of Health, and also here we are checking and monitor the severity of the cases. The patient happiness, that is combined of 2 factors that are the patient satisfaction score and the waiting time score. The patient satisfaction, we have scoring the satisfaction of our patient in the hospital to monitor in many areas such as the emergency, outpatient and inpatient areas. For the waiting times, we do have 9 waiting time indicators that is collected by the providers on a quarterly basis. And also we do have validating their scores. These are monitoring the waiting time in the emergency, how many times the patient is staying from registration to leaving the emergency department, as well as the waiting time in the primary care, and also if they have the appointment with a specialist or consultant doctors, so we need to monitor the time. We do have exclusion and inclusion criteria to make fair. For example, if the patient come to the consultant or the specialist appointment and the doctor asks for ECG test or hearing test or any of the tests, we exclude the time. So you can see these indicators in our website, the Department of Health website. I can write it down to you for more information. For the correct claims, to ensure the services and avoid any frauding in the claims, we conduct the correct claims and having a high percentage of the weight because of the importance of these dimensions, and we conduct a third-party company calling Tasnif to audit these claims. Next. Okay. So for the research and innovation, we encouraging the hospitals and facilities to check and if they do have researches to make it published and also to improve the healthcare system throughout these published researches and projects. We have different elements to measure the research and innovation, such as the ongoing, completed researches, the started researches also. We have also the health regulations assurance to ensure the patient safety and hospitals' readiness to have the patient with the best international standards. We have criteria, checklist criteria, and we have annual visits from our team, the health audit team, to check the hospital's performance and to add their score to the Mu'ashir as well. For staff happiness, we're ensuring the happiness of the hospital staff and the environment, regarding the environment, the salaries and other factors. And also it's been conducted by a third-party company to have separate score. And also we are asking the hospitals on twice a year to check the management. We are asking the management to check the staff score, and if they have low score, we're giving them an action plan to improve it and to make their staff happy as much as they can. For Safe Workplace, also we are providing and monitoring the staff, the safe environment for the patient, for the staff, and for everybody in the hospital. We do have also annual score and checking the safety of the hospital. The quality assurance certificate to ensure the patient safety by ensuring the accuracy of the quality data, and that is represented and collected by the healthcare providers. Also, this is conducted by the third party to check the validation and the KPI process review. Next. Please, if you do have any questions, stop me at any time and I can answer all your questions. Okay, so before going to the improvement of Mu'ashir, we have developed mathematical and statistical tool to get the composite score for each of the hospitals. As you can see that these are the 9 dimensions having different scores from one domain to another. So we have standardized them to get one score and make fair for everybody, and then we come up with one score and have the standardizing level at the standardizing score at the 2 level, the horizontal and vertical level. So at the end we have the tier from Diamond 1 to Diamond 5. So if the hospitals has 1 diamond, mean that they are meeting the requirement of the Department of Health, and it indicates that good performance. And Diamond 5 mean that these hospitals are exceptional and achieving the highest performance compared to all Abu Dhabi hospitals. We have announced the results for 2019 and it's in the media, and we have many hospitals got 4 diamonds or 3 diamonds, and we had 2 hospitals got 2 diamonds compared to all hospitals. You can check also the website to see how we celebrate with these hospitals to come up with this great achievement. Overall, we have also immediate and mid-term impact for Mu'ashir. You can see that we have 2.05 improvement in the patient experience, as well as we have 0.3 increase in the healthcare professionals, 1% improving in the achieving target time for seeing the doctor in emergency department. So don't look at the 1% is a small percent, but it's behind this percent there is a lot and of work and efforts to come up with this target. Also, we have 48 reduction in the number of cardiac arrest cases outside the critical care areas and 13% reduction in the number of unplanned readmission for pneumonia. 6% reduction in the rate of neonatal mortality. Next. So you can see that since we start in 2015 to get the data from 2014 till 2019, we have improved the performance, the average performance, and reducing the variation from the minimum to the maximum performance. So we are aiming for 2020 and 21 to have less variation as well. Next. Okay, so in the 5 years since implementation of Abu Dhabi Quality Index and the results in showing its impact on the system, we do have improving. Next. We have improving in, with 4.9 improving in the patient satisfaction, 14.1 improving in the access and waiting time. That is based on the 9 waiting times we had. And also we have 1.8 improving in the clinical care outcomes composite score. So this achievement, you can see that there are the composite score of the 9 waiting time, 32 clinical indicators, and the bunch of the patient satisfaction. So regarding the patient satisfaction survey, the latest one we do have for 2018, we can have in the patient score 85.5, and for outpatient, they score 78.3, and for the emergency, they got 72.5. We can see that they are better and higher than the GCC countries and the Press-Ganey international benchmark. Next. Okay, so for the healthcare accessibility and the timeliness improving, we can see that this is a quarterly from Q1 2015 up to Q4 2018. We can see that they got 85.7 and they end up with 97.80. Our target is 90, so they achieved the target. Next. Okay, so these are the major clinical outcomes improvement. We can see that these are very important indicators we are monitoring the hospitals based on, which are the hospitals acquired pressure ulcer, cardiac arrest outside the critical care areas, hip and knee replacement, readmission, and also the sentinel and adverse events. We can see that they are improving from year to year to reduce the cardiac arrest and also to reduce the readmission, as well as to improve the reporting of incidents. That means the culture, the quality culture of the hospitals is being improved. Next. So thank you. This is the overall our program that is regarding starting from Jawda to Mu'ashir. If you do have any questions, please feel free to ask me.
Thank you so much for that presentation. It was very informative. And I think it's very important as well when in hospitals implementing the frameworks in order to get good quality care. And it was good how you broke that down and showed us the different parts of that. So thank you very much for doing that.
Thank you.
Yes, I have a question. Can I?
Hi.
Yeah, sure.
How are you? How are you, Madam Juman?
Hi.
Actually, the KPI in DOH, they will start measure in Jawda first since 2014. But after in 2018, coming Mu'ashir, which increase the number of the KPI. Yeah. What's the difference in your statistic when you measure all this KPI starting from 2018 and when you start measure from 2014? Because in your study now, you show only the average for all over the 5 years together. Yeah. There is no differentiation between first 3 years and after with Mu'ashir in last 2 years.
Okay, so once we start in 2014, again, we have started with only 9 waiting time indicators and about 26 quality indicators.
Yes, right.
And this is calling clinical care outcomes. We have the score for the clinical care outcomes together. We standardized each KPI refer to the type of the indicators, such as the readmission, adverse event, complication, and other indicators. And then after that, after we getting the one composite score for these dimensions, we planned to have another dimensions to include it in Mu'ashir. So for Jawda, we have started with one domain that calling the clinical care outcomes. And after that, we have the other 8 dimensions that is measuring the different indicators. How we standardize each of this, because we have a low number of indicators, and then we have a multi-dimensions and indicators, we are standardizing them. How we standardizing them? To give them a standard score, let's say from 0 to 1. So this will not affect the number of indicators. So, for example, we do have this 26 in 2014, and for 2019, we have 32 indicators for the clinical care outcomes. We are using formulas. I don't want to be mathematician here, but okay, we have the formula that is the X performance minus the minimum over the maximum minus minimum performance to get the scores from 0 to 1. So these, all the scores will be from 0 to 1 to have one standard score. Is it answer your question, or you need more clarification? I can't hear you. Sorry, I can't hear you.
You're clear?
Yeah.
Sorry, the internet.
Okay.
Sorry. You clarified, so your clarification, it's okay right now. Thank you very much.
Thank you.
Hello.
Hello.
Yeah, I have one question. What should be the frequency of the quality indicator, the internal audit? Like there are process indicator also, there are clinical indicator also. So what should be the frequency? I mean, how we can measure the process outcome by the matching the quality frequency of the audit?
So we do have the health audit regulations that is coming to the hospitals on annual basis. They check their performance, the validity. They are checking if they do have any violations. Maybe they close the hospitals, temporary or permanent, and then they do have the action plan for them, as well as this health audit supported with another audit calling, which supported by the third-party company. We call it Tasnif, to check and validate and ensure that the other health audit is accurate, and make sure that it's fair to give them this X score, for example.
Okay. Is there any formula for the specification of the clinical indicator benchmark?
You mean the formula?
Yeah.
Formula, we do have it. You can go to our website and check how we calculate the results.
Okay.
And
okay.
we take the patent for this to the Department of Health.
Okay, thank you. Yeah.
Hello.
Hi.
Hi, this is Sarah. I just wanted to ask, these indicators are only for quality indicators, and there's another party who come and audit these indicators, right?
Yes.
Okay, so there's no compliance KPIs.
No, there is compliance KPIs, such as the reporting the adverse event. We do have the adverse event in the hospitals, and we are checking if the hospitals are reporting them on a quarterly basis or not, and this is the compliance. So we have the complication indicator and compliance indicators as well.
Okay.
Also, we do have the research and innovation that encouraging the providers and the public to put the researches.
Okay, so if I go to the website, I can actually view all these KPIs.
You can find all, yes, yes.
Okay, great, thank you.
Very good questions. Fadwa had a question. How did you develop your benchmark for clinical outcome indicators?
Yeah, we do have the benchmark internationally. First, we look into the other organization and countries if they do have the same indicators, and we do the benchmarking based on these indicators and the scores. And we have also the weight for each indicator that is international, consulted by the internal and external experts as well.
Excellent.
And also we compare the performance internally before going to globally.
Well, thank you very much. Has anyone got any more questions? If there is any more questions, just put it in the chat box. Let me just check. And everyone, if you can, check your chat box. Let's have a look. Is there any more questions? Oh, excellent. Ms. Waffer has her hand up. If you can ask the question, please.
Good morning. Good morning, everybody. Yeah, I have one question only for you. I just want to know if any professional from private sector can access to the quality indicator in the governmental sector.
It's for both the government and the private hospitals. We have started now with the hospitals, and we announced the results for the hospitals, and we are trying to expand the Mu'ashir to the other healthcare types, such as the home healthcare, ART, and other healthcare services.
Okay, thank you.
So this started in a private hospital, and then
we start with all hospitals that completed one full operational year from receiving the first patient.
Oh, okay.
Yeah.
No, there's a question in the chat box. Is there any from Malik? Is there any resources or support that is given for hospitals that are not scoring that well?
Yes. First, we're starting with giving them action plan to improve their performance. We're putting with them the weaknesses area, refer to these indicators. And then we, for the next quarter, we make sure that they've been improved. And this action plan, it's been signed by their higher management. And if not improved, they will score low as 2 diamond or 1 diamond, and it's published and announced to the healthcare providers. In the next phase, we'll have penalize these hospitals.
Excellent. Any more questions? Okay, well, if there's any more questions, I can put it in the chat box. And if I could please remind everyone to check the chat box as we go along. And thank you very much for your presentation.
Thank you.
Thank you. Okay, so now we have our next presentation. Our next speaker is Dr. Noha Ghanem from Egypt. Dr. Noha Ghanem is a specialist in oral and good morning. A specialist in oral and brilliant, you got your presentation. Director of Quality. She had completed her PhD in Business Administration from British Royal College. She had studied several areas of management, leadership, psychology, nutrition, project management, occupational safety and health, patient safety, comprehensive medical quality, and infection control. Writes short stories, novels, and the last novel has been published in the name of The Night Visitor, a collection of short stories in the framework of horror stories. I'm passing her the stage to deliver the speech.
First of all, welcome to you all. Welcome from Egypt. Today we are going to start about a guide of patient safety improvement. The guide is built on the following models and theories. Knowledge translation and the quality improvement. There are differences between them. We aim to achieve our goal, improve our patient outcome. Uses method and the process improve the quality, safety, and the value of healthcare at the local level. Knowledge translation, series, models, and framework move the knowledge gained from the research evidence into practice for large-scale improvement. Knowledge translation does not replace the quality improvement approaches. Rather, they are integrated to produce an approach to change for the significant situation impact on patient outcomes. Readiness and getting started. Assess organization readiness. That happens all the time. We have a good idea, change to attempt to put them into practice and often fail. When projects don't succeed, time, resources, and emotional energy are wasted as people attempt to make it work. The impact is that team members are less likely to adopt sometimes new in the future. Organizational readiness is assessed before a practice change is introduced. Organizational readiness begins with acknowledging the value and the importance of leadership and trusting in them to be ready for successful adaptation of a new practice changes. Engaging stakeholders. Identifying your stakeholders are their perspectives about your project is vital. Your stakeholders exist at the system level as well as a local practice level. They can affect or affected by the implementation of your safety. And they can certain position drawn from their value, accountability, received and losses and benefits. Engaging patient and family. Engagement accelerators improvement in many ways, especially by the helping to focus on safety issues and the solutions that matter the most patients. Actions that improve safety through engagement include effective communication and the translation . Sorry, I lose connection. Sorry, I lose connection. Incident management policies and practices are co-designed with the patients. Patient engagement for safety has dedicated leadership and resources, and there is transparency about safety. Enhanced teamwork and communication. Patient safety experts agree that communication and teamwork skills are essential to the delivery of quality of healthcare and preventing the mitigation errors and harm. Team steps, team strategic and the tools to enhance performance and patient safety was originally developed jointly by the United States Department of Defense and Agency of Healthcare Research and Quality. The program has been adopted by the Canadian Patient Safety Institute, and the Team Step Canadian was made available in Canada. It is a teamwork system that offers a powerful solution to improving correlation and communication with our organization. Number two. The barrier and the facilitators and defining the opportunities. Access barriers and facilitators to exchange. Once a problem are undefined, particularly to improve the opportunities, it is time to start thinking about what the implementation strategies will help overcome the specific barrier to practice change. There are tools such as CompB. We are going to discuss it below. That can help identify this barrier and facilitator barriers. For example, barriers for capability, opportunity, and motivation. Capabilities such as knowledge, skills, and decision-making and habits. Opportunity such as environmental context, social influences, motivation, benefits of capability, benefits of consequences, social professional roles, identifying, optimizing, goals, intention, emotions, and reinforcement. Measures, how we measure it. It is a setting to aim for our safety, improve project state in measurable. Exactly what you hope to achieve, what will be achieved, and the baseline and the target, and in what time period it will aim to be achieved. SMART target. Think about your aim in a relation to both process measure and patient safety outcome measure. The use of quality improvement tools such as affinity diagram, fishbone, Pareto, and the process map are also invaluable in defining the opportunity for improvement. The use of run chart in the interpretation using a run chart rules will support the telling you of the data story. That are the diagrams we use. Look beyond past harm. To improve your organization's patient safety, both qualitative and quantitative information is needed to help guide delivery of safe healthcare. A holistic conceptual model is used to accomplish these purposes, and a powerful approach to achieve our prescription for safety and our approach to its improvement, a framework help users move from assurance to inquiry. By shifting from relying slowly on a focus on a past cases of harm, but to include current performance, future risk, and organizational results. Identifying a change and the change idea. This section introduces components of quality improvement, such as change concepts and ideas that align with the measurement for our project and are derived from best practices. Adopting a care bundle approach means the practice change to or interventions which have been clinically proven to have the greatest impact are grouped together and implemented. This approach will result in significantly better outcome. Change ideas that align to the measurement in your project related to the specific clinical guidelines rather than tests of change that more broadly facilitate implementation of large-scale initiatives. Implementation strategies and analyzing your system. These strategies aid to overcome barriers, leveraging the facilitators and the performance, and the best practice being, often individuals cannot change their behavior aligned with the best practices. Analyzing the understanding the system by understanding the barriers, and the facilitators allow you to learn if the team members don't have capability, opportunity, or motivation such their behavior. Once identified, implementation strategies are selected to assist the individual and the organization to overcome the barrier and enhance the facilitators. The result of this direct link with the barrier and facilitators is the ability to select highly targeted and effective implementation strategy. We put them in a diagram like this: the capabilities, the opportunities, the motivation. And we put dotting on the sections we have and what we don't have, and analyze this. Contest and adaptation and designing tests of change. Analyze adaptation. We have some questions to tell me if I am capable of adaptation or not. Question for adaptation of implementation quality. Number one, is the adaptation planned or unplanned? Why is this adaptation being made? Is it because there is a logistic issues, or because there is a philosophical differences of people values and benefits about what we should done? What type of adaptation are being made? Change of the content or in the context? Number four, who is making the adaptation? The implementation team, the leadership, or the point of care staff? Who will be affected by the change? Implementation team, leadership, or the point of the care staff, or patient and family? Using rapid cycle improvement, it contains what and how. The what describes the idea, practice, change, and the how describes the strategies that will be used to change people's behavior. What is a clinical practice is well-established, evidence-based practice and does not need to undergo BDSA. However, for each team, it is not known which implementation strategies are the most appropriate. Therefore, BDSA should be conducted on the how, the implementation strategy, to design the tests of the change. Plan, do, study, act. For each item I have, to identify what and how. Implementation quality and formalize the standards changes. Monitoring the implementation quality. Implementation quality refers to the degree to which practice change or intervention is delivered as intended. It helps us to consider issues such as whether a change intervention is being used effectively, it is received as valuable or useful, it is reaching the intended target audience. There are 6 keys in instruction to be considered. Number 1, the dosage. How much of the intervention was delivered? How many training sessions did people attend? Fidelity, how closely the implementation adheres to the implementation strategies, core and components. How closely did the implementation follow the content? Adaptation, change made to the intervention of the content, adding, deleting, modifying the practice change. Quality of delivery. Methods of intervention delivery, implementators enthusiasm, clarity, etc. Reach, whether the intervention is reaching the target audience, what percentage of the staff receives the training. Participating, responsiveness, attendance and engagement. Are the target audience and participants interested in the receptives to the change? Sustainability, what is your plan? Sustainability and demonstrating the impact. Plan and sustainability. As the sustainability fit. Select implementation strategies that fit the organization mission, value, culture, and operating procedures. Once you have found the intervention that is a good fit, the next step is aligned planning. Determine the best method for integrating the intervention into the existing organizational structure. One approach is to enlist in a champion who will advocate for the practice change to management. Choose a champion who is respected by the management and understand how navigate the policies of the organization. How we make the change. Engage for sustainability. Let those carry out the change know how it could be benefit to them. People are more likely to change behavior if they perceive that there is a personal advantage for them. Describing the advantage of the new practice clearly can increase the change and the likelihood to individuals will communicate and continue the change to their behavior. Ensure opportunities and capability building and ongoing training in the new practice change. Enlist a champion, although it is likely to be different individuals than the one described above. This champion's role is to achieve implementation engagement, encourage and support implementers in the implementation and sustainability phase, and develop the strategies to overcome roadblocks encountered during the process. engaging patients and their families. In addition to engaging implementation, patient and family should also be engaging. Patient and families are participants who are most affected by the new change. This group must be considered the change to be beneficial in order to be willing to continue to engage and or encourage new patients and families to be involved in their core planning. Financing. Consider financial and other support based on what we have, include the different sustainability and the sustainability action plan. You can determine how much in-kind support and or funding the site will need to sustain the change. When considering sustainability, financial sustainability is often the first thing identified. While support and funding may be important in preceding sustainability, we would stress that it is not the only factor. Sustainability is similar to implementation with regard to funding, although some form of continued support or funding may be necessary to sustain a new change. Funding alone is not sufficient, and additional factors is needed to be addressed. Evaluate sustainability and demonstrate the impact. It is important to assess how the team will both plan and measure sustainability to demonstrate the impact. A list of questions is considered when planning for sustainability. How will you assess whether the intervention is continuing? How will you assess whether the intervention is continuing to impact in patients? How will you assess whether the original intervention continue to be delivered with high quality? What is your plan to ensure that partnership among stakeholders are maintained to support continue to use for the intervention? Plan for sustainability, spread, and scale. Once you understand the context of sustainability, including potential barriers and facilitators, the implementation team can work on defining what will be sustained and create the action plan that will address how to transition from the full implementation to the sustainability phase, and where the impact can be continued demonstrated. Thank you.
Oh, thank you very much for sharing that.
Any questions?
I thought it was very good in terms of how it highlights patient safety. In order to deliver optimum care, the quality indicators are good for achieving this. And it was good how it highlighted that. When I do have a question, if I may. When you have an action plan put in place, when something is realized, how long does it take to implement that action plan?
Excuse me, the voice for interrupting.
Oh, sorry. You know, when you have an action, can you hear me now? Dr. Noah?
Yes.
Can you hear me? Yes. Excellent.
Yes,
you know,
I can hear you now.
Oh, excellent. You know, when you get, when something happens and you have to build an action plan on top of that because of trying to respond to whatever's happened, and you think, okay, well, we've got to fix this. We've got to do something about this. How long does it take for an action plan to be implemented and carried out?
We return back to the plan, do, study, and act. It is non-end the cycle.
I can imagine. Has anyone got any more questions? Just checking the chat box. No, okay. Well, if anyone does have any more questions, then please do put them in the chat box and we will aim to answer them later. Thank you very much for your time, Dr. Noah. And thank you for a good presentation. Okay, so bless you. So I'm just wondering what's happening with the next person is, because the next one's meant to be Dr. Jamila, but I'm not sure if she's here. If she's not, we can always move on to the next speaker. While I'm waiting to hear from that, I just wanted to welcome everyone to the third day of the conference. And I hope you're on a good day. And the speakers so far have been fantastic. And I have no doubt the speakers that will follow them will be fantastic also. So because unfortunately, Dr. Jamila isn't able to connect with us at this point in time, so I'm going to pass on to the next speaker that would have been after her. And that person is Miss Fadwa Abu Mustafa from Saudi Arabia. She is a Director of General Assistant for Technical Affairs at Saudi Patient Safety Center, and I'm passing her the stage to deliver the speech. It's all yours.
Okay, just give me 1 second to connect, please.
That's while we're waiting, I was just hoping to highlight the utilitarian conference gathering and thank them for the support for this conference. And I hope everyone is having a good day. And I know the sun's shining is outside. So make sure your windows are open, get that vitamin D. You still there, Miss Fadwa?
I'm trying to connect, just give me 1 second.
Yeah, that's fine. I know Zoom sometimes can be a bit tricky.
True, but it will be worked soon.
I have every faith in you.
I think we had a really very good presentations today, really overall.
Yes, most definitely. I've enjoyed them all.
I'm a quality person, so really I enjoyed things. So I'll be sharing my presentation. Just 1 second. Okay. Are you able to see the screen now?
Not yet. Does anyone else see it?
How about
Oh,
now?
wait. It's sharing. Here we are. It's
You
all
are?
yours.
You are able to see now?
Yes, it's a bit echoey though.
Okay.
Have you got another device that's on at the moment?
Okay, let me leave this device and just focus on one device. I'm now using my computer laptop.
Excellent. It's much better. The sound is much better. Thank you very much for doing that. And the stage is yours.
Are you able to hear me now?
Yep, I can hear you clearly and we can see the screen.
Hello, good afternoon, everyone. Good afternoon, Adwa. Good afternoon, Kar. How do you do?
Okay, can I start?
Yep.
Okay.
The stage is yours.
Okay. My study is related to patient safety concepts among medical and pharmacy students, and I apologize really for this inconvenience that was at the beginning of the presentation. So basically, our study has been conducted as a collaboration between two entities here in Saudi Arabia. The first entity is our hospital, which is King Faisal Specialist and Research Center Hospital, which is a tertiary specialized hospital, and the University of Al Faisal, which is basically an affiliated university that's joined in an agreement with our hospital to provide kind of training and also education for the students who are also considered really part of our customers in the hospital. So starting with the hospital, as what I mentioned, it is an academic medical center, and basically we do have other branches. It's not only located as a Riyadh center. We have a branch also in Jeddah and another branch in Al Madina city. The total number of beds for the three branches is around 2,000 beds, and also we are having a large community of employees, around 15,000 employees. The main services that's provided by the hospital, in fact, what I mentioned, we do focus on tertiary specialized care for our patients, and we provide medical genetics, organ transplant, oncology, cardiovascular, and neurosciences. But also those are the areas of excellence of our hospital, but we do also provide other type of services that's needed for those patients as also a help for them in order to be having more of comprehensive and more of holistic care in our organization. The university, as what I said, is affiliated with the hospital, and we do also care for the students at all levels, if they are undergraduate or postgraduate. So undergraduates, they do receive also educational training, educational and training in our organization. And at the same time, when they became residents or postgraduate, we do also support them by doing training. Now, the university is one of the best ranked in the region, and we have two colleges in this university, medicine and pharmacy, that we as a quality management department work closely with them in order to try to develop and help those students in order to be an excellent postgraduate residents or also workers in our organization. So our observation as a quality management department, you know, we do receive many patient safety incidents, and we do have a system to capture those incidents from different departments in the hospital. And what we have noticed that there is a trend of certain incidences that comes basically from those postgraduate students, especially patient safety incidents, especially related to medication and providing care for the patients. And part of what we also observed that the way how to handle those incidences from the students was really not clear to those students. And we thought there is a need to tackle this area in one way or another in order to be able to really help our patients also who will be cared by those students and by those residents or postgraduate of course, students. So we had this agreement between the quality management and the university, and we started this research project. And basically, the focus of this project was mainly to assess the knowledge of those students in the university in relation to patient safety concepts. So this is basically the collaboration and the research principal investigators, which was myself as representing the quality management department, and also the university, which is again also the top level of the university was contributing to this study, which is the Dean of the College of Medicine. Also, we wanted to empower the students, so we selected also one of the students to be with us as investigator or principal investigator to help the students also in order to be able to collaborate with us answering the questionnaires or helping us with the study. Also, we are considering the research, the whole research, as a way to educate our students in order to be able to do researches individually later on. So basically, we went also with formulating a team for the research, and we tried to also include other members from quality management, mainly patient safety, and also we included other students who will be helping in capturing capturing the data from the university students. The background, as what I said, is really the incidences that we have found. But when we went to look into the literature, we found out that there isn't, in fact, any structured way of training patient safety in the universities, whether government or private. And this is not limited to Saudi Arabia, but also it is cross-border in other countries. like China. We looked into China experiences, we looked into Australian experience, and basically all of these experiences were alluding to the same conclusion that there is variation. There isn't a structured way of teaching the safety concepts in the different countries, universities, whether they are private or government. So we thought, so this is an opportunity to do the research, and we looked into what can be the aim for this research. So basically, our focus is to assess the knowledge and attitude regarding patient safety concepts for undergraduate medical and pharmacy students of Al Faisal University. And those are the concepts that we were focusing on: the types of human errors, reporting of errors, factors that contribute to human errors, how to speak up, and at the end, patient rights. So those were the main focus for our study. In relation to the population of the university, basically at that time, we did this study in 2019, and we had at that time 1,303 students in the medicine and 65 pharmacy students, with total of 1,368 students. So we looked into, we cannot of course cover all of those, so we tried to get a sample size from those students, and we thought we will try as much as possible to reach to 3 or 4 of those students completing our study to achieve 95% confidence level and 5 confidence interval. And we built and designed the survey to collect the feedback from the students. Our results, we were able, in fact, out of the distribution of a survey that sent to the students to calculate, to collect 3 or 4 survey that was completed by the students, and that made like 22% of the total population of the students in the university. Now, the questionnaires were 15 questions, and they are really quick to complete and easy to respond to. And basically, we wanted just to know if the students are familiar of the concepts that I mentioned before, and they are comfortable with applying them. The survey was conducted in the period of from March to September 2019 in the university with the help of the students who were part of the research. And we tried to make it as anonymous survey, so that will encourage the students, as sometimes they fear when they respond to such type of surveys. It might include, you know, that they are not familiar about certain concepts. And we did analyze the survey results as a quality management in order to ensure the validity and the the accuracy of the evaluation of the results. So the questionnaires in general, it's included in my presentation. So the first part of the questionnaire was mainly the demographics of each student, and was, as what I mentioned, we tried to eliminate the ID number, the university ID number, from the questionnaires, and to encourage, you know, more participation. And we tried as much as possible to get the important information that is needed for us to do better analysis. The second part of the questionnaire was mainly focusing on getting the feedback from the students in the availability of the patient safety course, and also the ability to see what their interest in the format and the type of that course that will be provided for them, whether it will be in a presentations format, video, or hands-on, or so on. Yeah. Also, the fourth group of the questions focused on the assessment of the knowledge of the students And we did give them different areas of patient safety to look into their ability and their knowledge of understanding this area, and if they are able to work with those errors in a proper way. We included also in this part the patient rights. The last part of our survey did focus on questions related to handling errors when it happens and whether they are capable of handling those errors in the proper way. And we gave them different direct questions in order to monitor and see the way how they will deal with the errors and if they are comfortable in sharing those errors and handling them. The results from our study showed kind of interesting results. So basically, in relation to the knowledge and understanding of the errors in the healthcare, we found out that almost 50%, like the results was 50-50. So 50% of the participants showed really good understanding of the different types of human errors and the contributing factors and others, but other 50% did not really give the same level of understanding of these areas, which provide us with a clue that we really need to do more and to work more on those areas. And basically, the students who are at the higher level of their study, at the postgraduate, or they are exposed already to the clinical areas, they have a better understanding of this area more than those who are just in their initial years of doing their enrollment to the university. The other part, and was interesting for us also, that we found out that in most of the areas, there was really good understanding. From the graph that you are seeing here, the green is basically the positive feedback, and the other colors are the negative feedback. And in most of the areas, really, there is a good understanding from the students about patient safety. However, we found out that they have a hesitance in sharing the errors with others, and they felt that they will mostly share those with only trusted colleagues. And this is one of the things that we also observed when we are really working within our hospital with the incidences that we are seeing. And all of you know that sometimes in our organizations, there is a hierarchy of the services and the authority. And normally those students will be reporting to their program directors and not to the units or the areas that they are working in. So where to report, where to share, and sometimes they are hesitant to share if something happened and it might impact their grades or scores in the university. So this area of Speak Up, we need to really focus too much on it in the hospital and try to promote more empowerment for those students when they come to our organization and start to practice and care for patients, because they will be considered accountable, similar to other staff within our organization. So in conclusion from our study, this is what we came up with. So basically, we have approximately half of the survey participants had an acceptable understanding of different types of human errors. However, they had little knowledge about the factors that lead to these errors and how to report them. So in the area of handling those errors, we found a big gap among those students, and also those students also will be later on postgraduate. So if they have this gap when they reach to the postgraduate and become residents, we will continue to have this gap. So we need to work this out. Most students understand the significance of patient safety education and showed eagerness to learn more. So they did really requested that to have a well-structured, patient safety course for them. Students recommended having an additional elective course on patient safety offered as part of the curriculum to achieve this goal. So they wanted something specific, and we found out from their response that most of what has been given to them is bits and pieces in different courses. It's not well structured, one course that will give them the whole concept or the whole story about patient safety. There was a strong recommendation also from the students to expose undergraduate medical and pharmacy students to real life patient safety situations. So yes, they are in the university, but they will come to the real world soon after finishing their studies, and that would have been an issue for them if they come back to the hospital without being exposed to what they will be faced with in the real life. So this exposure will enhance the students' ability to handle situations they may encounter after graduation. So this also mandates more collaboration between the quality management, who really know the real situation, with the university, trying to bring the clinical part to the academic part and make them mutually available for the students in their university. Al Faisal University will be considering the results of the study and building a patient safety course for the students enrolled in the College of Medicine and also the College of Pharmacy, and collaboration with the Quality Management Department of the hospital will be established to provide the students with more practical examples. What we wanted really to what was requested by the students is to have more hands-on, to see really real case studies of patient safety and how to handle them, and to present something from what we are capturing in our quality management department. With this, I will conclude my presentation, and I hope you have enjoyed, what has been presented to you, and I'm happy to receive any questions related to it. Thank you.
Well, thank you very much for that good presentation, Ms. Fadwa. I thought it was really interesting. As a student myself, I definitely thought it was quite interesting how they checked for patient safety, their knowledge and understanding of that. And then after that, they basically implemented that change to try and get that across to them before they actually went out without the safety of a mentor. Or that's pretty good.
Yes, and to tell you the truth, we are looking into implementing the outcome of this study cross-board in other universities as well, and we are hoping after publishing our study, it will be published soon, inshallah, to have and to encourage other private and government universities to be considering this approach and working closely with the quality departments to help them.
That's brilliant. Really good. Has anyone got any questions for Ms. Fadwa? Check the chat box. Anything there? Remember, everybody, to check your chat box.
Let me see. Let's see anything here.
If there are no further questions, hopefully there'll be any questions, put it in the chat box and we can answer it later. And Ms. Fadwa, thank you so much.
Sure, my pleasure. My pleasure. Thank you very much for also the organizing team and everyone. And sorry for the beginning of the presentation, the inconvenience happened. Thank you. Have a good day, all of you.
Thank you. So our next speaker is Dr. Amal Fathella, Dr. Amel Fathella from Egypt. She's completed a PhD from Manufia University. She's an assistant professor at Manufia University, and she is an active member of the Egyptian Society of Child Neuropsychology. She has published more than 15 abstracts in different journals. She participates and attendance in many international nursing conferences, research and education. Are you there, Dr. Amel? And she will be presenting. Can you unmute the... Hi, Dr. Amel. Hello.
Hi.
Hiya.
Good afternoon.
Good afternoon. How are you today?
Give me 1 second, please. Okay. Can you hear me?
I can hear you and I can see your screen. I'm passing the stage on to you.
Okay. I will discuss now about the cholesterol proprietary effects on maternity, mother's knowledge and beliefs. Mother and the children, can you hear me?
Yeah, we can hear you. And we
Okay.
can see the presentation.
Okay, mother and the children consider 1/4 of the total national population. They are the most group to ill health. The most causes of neonatal mortality and morbidity may be inadequate breastfeeding, following a faulty breastfeeding technique, ignore of mother regarding feeding practice, lack of health education given by the health providers. Breastfeeding should be initiated when I need to biggest the slide, but I don't have.
So you can put it in the full screen. So if you put go to Is it going into the full screen?
Okay.
Oh, there it is. That's perfect.
Breastfeeding should be initiated within the first half an hour after birth. The first milk is the most suitable feed for the newborn. It's called colostrum. It is the thick and yellow colored milk. For most of the children, breastfeeding makes the difference between the life, death, and it's in the infant. It's become what's called a passport to life. Also, it can be considered as the first vaccine which needs a warm chain. It's made by mother-infant contact, and it's secreted in very less amount, about 30 to 100 milli. So the mother need to be explained that this small amount of colostrum is adequate for infant and not must be denied. Colostrum is universally the perfect and the best first food for the newborn. It is produced after the birth and lasts from 2 to 4 days after the lactation has started. It is a source of the fat, protein, sugar, and many forms of vitamins and minerals. There are 90 known components in the colostrum. There are 2 main primary components of colostrum, immune factors and growth factors. Immune factors in colostrum feeding are the source of passive immunity achieved by the mother and is transferred to the baby. It's helping in baby to fight against virus, bacteria, fungus, and yeast. To give the newborn babies the following specific antibodies, there are around 20 specific antibodies in the colostrum to fight microbes like Salmonella, Staphylococcus, Streptococcus, Candida. Immunoglobulin, it has role in both treatment and prevention of viral, bacterial, yeast, and fungus infection, and also allergies. Protein-rich polypeptide, it is stimulating to regulate the immune system in the body. Lactoferrin, it is an iron-binding protein that have important role against the cancer cell, has antiviral, antibacterial, and anti-inflammatory properties. Cytokinase regulate durations and intensity of immune response. Lymphokinase, it is act in mediating the immune response. Glycoproteins and trypsin inhibitors that protect the immune and growth factor in GIT. Like leukocytes, it stimulates in interferon, reduce that inhibitor cellular wall penetration and slow down the viral reproduction. Growth factors that's important to stimulate growth, help in regeneration and accelerate the repair of age original muscles and skin, collagen, bone, cartilage, and nerve tissue. There are many growth factors in the colostrum. Epithelial growth factors, it is a protective and maintains the skin that can stimulate normal skin growth and repair the cellular tissue, transforming a growth factor A and B that stimulates the proliferation of the cell in connective tissue and assist in informations of the bone marrow and the cartilage. Platelet-derived growth factors, it is help in cell division in connective tissue, smooth muscles and fibroblasts. It also helps neural survival and regeneration. Vitamins and minerals, they are most important nutrients essential for the normal metabolism, growth and development. Amino acids are the building blocks of proteins and required for growth and development of the newborn. Lack of knowledge regarding colostrum feeding is the major causes for the infant morbidity and mortality rates. So pediatric and maternity nurses are responsible for ensuring that they drive a high quality of knowledge and positive beliefs for mother about colostrum. Because there are limited pediatric and obstetric studies that acquisition the mother's adequate knowledge and the positive beliefs about the importance of the growth and immune factors in colostrum and its role in newborn babies has this study. So this study aims to evaluate the effect of guidelines educational programs about colostrum on mother's knowledge and belief. Significance of study. Breastfeeding is the ideal method for the psychological and physiological needs for the infant. Breastfeeding gives adequate warmth, affection, and security, as well as food protection to the baby. Yet, statistics from around the world reveals that colostrum is frequently discarded. There is widespread lack of awareness of its qualities and its key role in contributing to the health and the growth of the newborn. Feeding water or other liquid of colostrum instead of colostrum differs the child of good starts in life. The WHO child growth standards show how all children should grow, and the babies feed colostrum within the first hour measure up well against this standard. There are about 120 million underweight children around the world. 3 million die each year as a result of being underweight. WHO recommended that all children should be exclusive breastfeeding for 6 months. Feeding colostrum in the first hour is the first step. It's very important that every child receives the colostrum to get ahead in the race against malnutrition and protect him from the infection. Research hypothesis in this study, maternity mother knowledge about the colostrum will be improved significantly after their participation in the guidelines educational program than before, and have strong positive beliefs related to colostrum. Research design, quasi-experimental research design will be utilized to conduct this study. This study was conducted at the postnatal care department in Nufia University Hospital and Shibin al-Qom Teaching Hospital. The result, table 1 showed that distribution of studied mothers according to their biosocial characteristic. According to their biosocial characteristics, their age range between 60 and 40 years. As regards the educational level, it was about from the table that half of studied mother had illiterate, while 50% had university education. Regarding the readiness, about 1/3 of the mothers were from rural area, while slightly more than from the urban area. Considering the type of the family, about 3/4 of the studied mothers had nuclear family. Table 2 showed that distribution of studied nursing according to their obstetric history. About 1/3 of studied mothers were pregnant for the first time, and about 2/5 of them were pregnant for 2 or 3 times. The lowest proportions of them got pregnant 4 times or more. Table 3 shows that the first nutrition given to newborn, most of the mothers gave sugared water upon the birth of their babies. They gave these nutrients until the production of the white milk, usually for up to 3 days. Some mothers gave different kinds of nutrients in the first day of life. Nearly 1/4 gave herbal fluids, especially were regarded as having creative effective on digestion and stomach ache. Additionally, herbal fluids were considered to clean the stomach of the baby. About 1/4 is of studied mother give breast milk. Table 4 shows the reasons for not giving the colostrum as stated by some mother who didn't give their infant breast milk within the first hour of birth. Mothers believe that colostrum is always produced within the first 3 days of birth, and that it should not be given to newborn. Mothers reported that colostrum causes stomach ache, and the infant dislikes this milk. Mothers squeeze their breast to get rid of this first milk until white milk is produced. Table 5 showed distribution of studied mothers according to their time of initiation of breastfeeding. It was shows that more half of studied nurses initiate breastfeeding with the first 1 hour, while about 1/3 of the studied mother initiated breastfeeding between the first hour and to 24 hours. The lowest proportion of them initiate later than the second day. Table 6 shows that the distribution of studied mothers, the total knowledge about colostrum on pre, post, and follow-up educational guidelines program. It referred that the majority of the mothers had more knowledge about the colostrum in post and follow-up than on pre-intervention. Therefore, there were highly statistical significant difference between mother's knowledge. Table 7 showed distribution of studied mother total positive beliefs and the total negative beliefs on pre-post follow-up. It displayed that there were statistical significant difference in relation to mother total positive beliefs and the total negative beliefs on pre-post and follow-up. Total ill person correlations between the total mother knowledge, positive beliefs, and the negative beliefs about cholesterol. It's showed the highly statistical the difference between the mother beliefs about the negative and the positive beliefs. This study concluded that guidelines education program about cholesterol improved most of maternity mothers' knowledge and beliefs regarding the cholesterol. Recommendation: guideline education program about cholesterol should be performed to upgrade maternity mothers' knowledge and belief regarding the cholesterol, engaging the social and the family decision maker involving mean to motivate and support the mother, establishing peer support social network, creating awareness through mass media about the benefit of the early and timely initiation of breastfeeding. Thank you for your listening. Thanks. I'm happy to receive any questions related to this topic.
Thank you for sharing that, Dr. Amel. It was a very good insight in child health and development and learning more about the importance of colostrum.
Yes.
So thank you very much for sharing. Is there any questions from anyone? If there are any other questions, please can people put them in the chat box and we'll hopefully answer them later on. Thank you very much again, Dr. Amel.
Thank you.
I have a question.
Oh, we got a question.
Yes. I would like to ask, because we are in COVID era, I would like to ask if the mother is COVID positive and she delivers, despite her delivery, it's infection or normal delivery. So you would recommend her to start and continue breastfeeding. This is my question.
I can't hear it. I can't hear some.
Yeah, my question is regarding to the woman who delivered and she's already COVID positive. When she will deliver, do you recommend her to continue to start and continue breastfeeding to the newborn, her newborn?
Yes, you must continuous breastfeeding because it have many important elements about the how about the cholesterol is very important to fight the bacterial and the viral or any infection.
Okay, thank you.
Any question? Any other question?
Okay, well, that was a really good question. Thank you very much, Dr. Amel.
Merci.
So the next speaker is Dr. Malik. Hi, Dr. Malik.
How are you?
I'm okay, thanks. How are you?
I'm good. I'm quite good.
Excellent.
Thank you for having me.
Oh, bless you. Thank you for being here. Are you able to tell us a little bit about yourself before presenting?
Well, yeah, I've been in healthcare management for the last 17 years. I've been in different roles in hospitals mainly, and I've worked mostly in Lebanon and some Middle Eastern countries. And I've been into different studying different kind of things like operations and simulations and roles of different healthcare workers, and but today I'm gonna talk about something a little bit different. It's more conceptual for the healthcare model.
Excellent. I look forward to hearing your presentation. The
okay,
stage is yours.
I'm gonna try to share my PowerPoint. Just give me a few seconds.
I can see the PowerPoint.
Okay, I think it was shared on your half.
Yes. Yes.
All right. That's quite perfect.
Excellent. Well, the stage is yours, Dr. Malik.
Okay. Thank you for organizing this conference, and thank you for everyone tuning in. I know I really appreciate your time. I know how much of a hassle to watch a webinar online, and thank you for the organizers who made it easy for us and made this conference such a successful one. My talk for today is a case for the future of the hospital, rethinking of the healthcare roles from first principle thinking perspective. I'm going to start out by showing some pictures and then talking about a story behind this picture. Next, please. This photo is a photo of the first computer in the early 1950s that's assembled by the famous IBM computer company and by collaboration with Harvard University. This machine was the start of the discipline of computer science, and it was kind of a massive machine. It's 50 feet long, 8 feet high. It consisted of different interlocking panel of small gears, counters, switches, control circuits. It also had like 800 kilometers of wire, and it constituted of about 35,000 counters, 10-pole switches, and tires. So this machine was the start of the discipline of computer science. Next slide, please. And actually, the company at that time had 1,000 pages manuals about how to operate such a machine, the logistic of moving it around, how each role, each person had a role in functioning the machine, of supplying the necessary gears, interlocking tunnels, vacuum tubes to make it work. They even had a plan and policies inside about how to give access and restrictions to each part of the machine and how to coordinate everybody's work together. They even had plans how to supply the metal and the gears that are necessary to operate and the wires that are necessary to operate such a machine. And that's how computer science started, with this massive equipment. And these roles that I've mentioned could have been grown and become established roles and with a certain education. But something different happened. Something called Moore's Law. A person called Gordon Moore had a theory, or it's more of a prediction, that the number of transistors in a dense integrated circuit, which basically is a chip, the electric chip, will double every 2 years. And this kind of thinking made people in this sector think about computer science quite differently. What Gordon Moore did is shifted the thinking into the basic part of the computer, which is the chip, the electronic chip, and made everybody think about how we're gonna make it better and how to be the first to double it every 2 years. And that shifted the whole computer science pathway from a great big room, 20 feet long machine into empowering these little chips. And after the famous IBM photo I just showed, the machine, the Mark I, two guys, next slide, please, that you're quite familiar with, came into computer science, Steve Jobs and Bill Gates. And these people, they were pioneers and visionaries, and they were the first to lead computer science into getting this chip, making it more powerful. And their competition between them made even the science advance even faster. And they started thinking about the basic component of the computer, which is a chip, how to double it, how to make computers more powerful, how to give us personal computers to enter each and everybody's home. They started working on the design. They started working on their practicality. And they started removing unnecessary parts because they wanted to make it more compact and more easy to use. And they started making it user-friendly, multi-windows, and software that's easy to be understood by everyone who's using this. And then something else happened, which is the internet. And they took advantage of this. And they started combining communication with computing. And now everybody is using a computer right now, either for listening or presenting a lecture in this webinar, or the smartphones in our hands. Basically, we cannot live without them. Next photo, please. This is the photo of the steam engine car, one of the first cars that is, or a horseless carriage. It was the beginning of automobile manufacturing. And if you can see this photo, it has three guys. One of them, the one with the fancy hat and the bow tie, is the man who owns this car. And the two other guys are the ones who are operating it. The one in the front, let's call him the steerer. He steers the machine left and right. I think it only goes forward, doesn't go reverse at that time. And the other guy in the back is the guy responsible to put the coal inside the steam engine. And this is an external combustion engine. It needs coal. He needs to keep enough coal inside of the machine, the engine, and he needs to keep it ignited and make sure he always is there and watching these coals. And let's call this guy the coal steerer, if you want. And that's what happened. That's how car manufacturing started, from a horse-led carriage to a horse-free, self-operated car. And those two roles could have the steerer, and the coal dispenser could have evolved and could have their own functions and could have their own unions and syndicates even, but something different happened as well. Pioneers came into this, into car manufacturing. We remember Mr. Benz of Mercedes-Benz, and I want to quote Mr. Henry Ford. Please, the next slide. Next slide, please. And in his autobiography, he says this famous sentence. He says, "As we cut out useless parts and simplify necessary ones, we also cut down the cost of making." It's a simple sentence, but it has a lot of important factors inside of it. And I want to stress on the word simplify necessary ones, simplify the necessary parts of the car. And in claiming that, Mr. Henry Ford, what he did is he asked everybody in the car manufacturing to focus on the basic part, the basic parts of the cars. And the basic cars at that time was the engine. Wheels are important, lights are important, brakes are important, definitely, but the main powering, the main innovation that came with a car is the engine that would provide the power that used to be provided by horses or other animals at that time. And this focus, starting with Henry Ford and the European manufacturing and later the Japanese companies, they started thinking about the engine, and the engine started moving from being a steam engine to be a diesel engine, then a gasoline engine. And then they started making more efficient gasoline for those engines. And the engine itself started going from a 1-cylinder piston engine to 2-cylinder, 4, 6, and 8. And even we have 16 now and 32 cylinder engines. And the car became more powerful and faster and more convenient to be used instead of the horse-led carriages. And then I'm gonna focus on another part of this sentence. As we cut out useless parts, cutting out useless parts, and that's as much as important as simplifying the necessary ones. Let's remove the extra metal that we don't need. Let's try to find a metal that weighs less. Let's remove any furniture that's not very convenient and that just makes our the car more clumsy. And this process started improving until Henry Ford created what we famously know him for, the assembly line. Mass manufacturing of cars and bringing the car, the luxury of a car, to millions and millions of people. Now, most of us can picture our lives without one. And this was the important part or the milestone which made car manufacturing a smooth, lean industry. Next slide, please. This slide is a space rocket shooting up into space. And I want to go to the next photo as well. Please, next slide. And the electric cars. And this is a picture of an EV1 electric car, one of the first few electric cars. It was produced by General Motors. And those who are familiar, when they see those two photos, one person comes to their mind. Next slide, please. And that's this guy, Elon Musk. And you have to know, actually, Elon Musk was the one who coined the term in the modern era of first principle thinking. And when they asked him how you solve the problem of electric cars and space discovery, he said that my answer is by adopting first principle thinking. And I'll explain first principle thinking in just a few moments. Thank you for bearing with me that much without talking about first principle thinking or healthcare, but I will be there in a moment. So you have to know that space discovery had this big boom in the 1960s when they put a guy on the moon, and everybody knows about that. And then kind of the hype just died down. And yes, there were some improvements, and yes, there were millions and billions of dollars that went into space exploration, but nothing major happened. And that's what Elon Musk was questioning for some time. And he wanted to break the mold of space discovery, and he had the passion for it. And the same thing with electric cars. Electric cars had started out with the EV1, the picture I just showed you, and it just got stopped for like 20 to 30 years without any mention of electric cars anymore. And the ones that were brought to the market were inefficient, were slow, and were not that powerful. And actually what Elon Musk said he did to solve these problems is he used first principle thinking. And what he did is he broke up the problem into basic parts and then took the basic parts and re-engineered the manufacturing of rockets and electric cars. And here I want to, let me see if okay, next slide, please. Okay, so are we asking healthcare to borrow from other disciplines. I did show this photos and mention these stories of other disciplines and industries for a certain benefit for healthcare. And we have to know that healthcare had always borrowed from other disciplines. We had taken the Six Sigma from a communication company, from Motorola, the PDCA, that a lot of quality efforts depend on it, and the lean management came from Toyota, a car manufacturing company. The checklists we have for patient safety, the timeouts, and for the operations, and in many patient safety models, we got it from airplanes and the airline industry, where safety was a very important component of not having any failure in airplane flying. So we always took and borrowed successfully other things from other disciplines. But what we did is we have borrowed the tools. And what I'm asking, next slide, please. Next slide, thank you. I'm asking to borrow the thinking. Next slide as again, please. And here the thinking is first principle thinking. And I'm gonna explain it by having this pyramid-based 3-layer thinking. It starts with the base of the pyramid. It's the identification part. And here we ask ourselves, what is true about any industry? What is the reason for this industry? What are the problem we are solving? What is the hurtful thing we are trying to mend? And what are the assumptions? And you have to know that when a science or any discipline stays for quite a while, many of the assumptions become truths. And some of the real truths become forgotten. And what the basic function, the first stage of first principle thinking should be identifying the truths about the discipline of healthcare. What is true? What is the reality? What is the reason? What is the mission of healthcare? And what are the assumptions we had? Second stage is the breakdown. We break whatever we have into smaller parts in order we make the truths into units that are manageable, and then we are ready for the third stage and the final stage, which are presenting the solution and reassembling everything based on effectiveness. So it's identification, knowing what's true, putting all the information, getting all the data and putting them into small structures, and then reassembling and re-engineering any discipline into an effective one. And actually, although Elon Musk is the one who coined it in modern history, this kind of thinking started long, long ago. It started with the birth of logic and science. Next slide, please. Aristotle, those who know him, the famous philosopher from 350 BC and more, he's mentioned as the first one who mentioned first principle thinking. And you have to know that at that time, philosophers were not just people who profess about things and theorize. They were the closest things to scientists. They were the people who were asking the wondrous questions and trying to find logical solution. And the most important achievement they did was creating logic and putting the standards for it. And from that came science and the scientific method. And Aristotle himself was interested and had his studies in anatomy and biology, in physics and in math. So he was the first one who used the first principle thinking to solve the problems he faced in any of those disciplines. And then Descartes quite clearly described it, that you have to deduce everything to its basic parts until it's no more deducible. And then physics took over and started thinking about matter, and we started having technology that even Stephen Hawking quite famously said that philosophy is dead and science now have found out all the answers out there. And math and physics wanted to know what's the basic part of a matter. And then they found out that there's an atom and all matters around us are made from atoms. And then the atom, they found out that it even have smaller parts. They are made of neutrons and electrons. And then in the last 2 decades, a lot of effort and a lot of science and technology came along. And now they know that even electrons and even neutrons are made up of smaller and smaller parts, quantas and strings. And this is how this is how the evolution of science, of physics, of car manufacturing, of computer science, of space exploration, electric cars have started by adopting this simple yet not very easy to implement kind of thinking, and which is called the first principle thinking. And now, sorry for taking that long, I'm gonna go back to healthcare. Next slide, please. So what is true about healthcare? Doctors deliver care. Nurses contribute in the delivery of care. Diagnosis is done using radiological and laboratory equipment operated by highly qualified professionals. Treatment is provided as per the latest pharmaceutical products. Are these the truths? Pharmaceutical companies conduct research for long years and present drugs after all trials of safety and efficacy are done. Third-party payers provide healthcare payments between patients and providers. These are given in modern healthcare. But I want you to reread the slide, but now without reading the red words. I'm gonna read the slide again, but without the red words. Deliver care. So that's what's important, and that's the truth. The truth is healing. The truth is that we get sick, that these people get sick. We as a human race, and even as animal race, we can't be well all the time. And we need healers. We need people who take the sickness and find out what it is and deliver the right care. So the most important truth about healthcare, the problem we're trying to solve is not the roles, it's delivering the care. It's the sickness, maybe prevent it, maybe figure out what is it and try to solve it right away. Contribute in the delivery of care, the second bullet point, contribute in the delivery of care. Who contributes, how to contribute, and why to contribute? The different roles that should be involved, the team that should be structured around the main issue, which is delivering care, about diagnosing what's wrong. And here's the third point. Diagnosis is done using equipment operated by highly qualified professionals. And here, my point here in the third, in diagnosis, that diagnosis should be pushed by the basic truth, which is delivery of care. The people, the team who's working to diagnose, they should be pushing the equipment and the technology to come their way according to their priorities. Same goes for pharmaceutical companies, which is the fourth point. Treatment is provided as per the latest products. Treatment should be provided based on the recommendations of those who treat, of those who think that the priority and the most frequent sickness or most complex sickness is such and such, and they have to push the pharmaceutical companies or whoever is designing these drugs and deciding on what drug to research and to bring it into the market to research these drugs and put them out there for the treaters and the people who are responsible for the treatments to use. And even I'll go to the last bullet point, and it's provide healthcare payments between patient and providers. Third-party payers now are just a given in our healthcare system in every country that we don't even think twice about them not existing. And here I want to go back to the saying by Henry Ford. It's on the, I think, the 6th slide. Henry Ford's quote that I mentioned before says, "As we cut out useless parts and simplify necessary ones, we also cut down the cost of making." Thank you. I'll say it again. As we cut out the useless parts, we're removing everything that was useless, that's not value-based, and that is so the core of modern healthcare now, the value-based healthcare, cutting out all the useless parts that of not that being patient-centered and only contributing to the things that matter to the patient, cutting out the useless parts and simplifying the necessary ones, we also cut down the cost of making. Going back to the third-party payers, and here, the gift, the present, the reward that we get by adopting first principle thinking is cutting the cost, is removing the bureaucracies, is not needing other parties and other layers of and other stakeholders to organize different features of this healthcare. And I'm not saying that we will not need them, but they will be part of the system. They will be under the truth, the real truth of healthcare, which is to heal, to prevent sickness, and to make people, to diagnose better, and to make people, to treat people even better. And that's how all the stakeholders right now involved in the healthcare system will be integrated in this team who diagnoses and who treats and who pushes the technology to be so he can diagnose better, treat better, and heal. And more truths about healthcare system that are common in modern, next slide, please, that are common in healthcare right now, is that the level of automation and becoming more paperless can help hospitals become more modern and cost-effective. Proper documentation of care leads to less medical errors and better communication between different providers of care to a patient. Access to care is restricted due to the high expenses of healthcare and unavailability of specialized care in remote places. I'm just reading them out loud because these are truths and these are important in the modern healthcare. But automation and paperless and documentation and communication and access, these are all byproducts and bandages to a bleeding healthcare system. And we have heard, next slide, that healthcare, please, healthcare systems are complex systems, and that healthcare is in need of this desperate need of a disruption, of innovation, of a new technology that will help it go out of its mold. But in truth, it's built in a bureaucratic way that's keeping it that way. And right now, all of these things that we're coming up, and they're really improving the healthcare, but it's like just bandages on a very bleeding and sick discipline, which is healthcare itself. Please, the last slide. And the system is suffering right now from high expenses, from medical errors and malpractice to those honest physicians who are trying to treat those complex cases and they get hit by malpractices. It's like telling them to stop. And access to the care, either because of the expenses or because of the remote areas that do not have specialized centers near them, the inequity of care, the burnout of physicians, the burnout of nurses, the burnout of all those healthcare workers associated with the current healthcare systems. And the only way, in my opinion, is to adopt a different way of thinking, of how we used to do things in healthcare, to use basic components, go back to the roots, go back to the truth, build up again, make a cohesive team, think about a team that shares an equal level of power between them, that have proper coordination, that have proper communication, that have a well-developed authority matrix, that all team members are empowered, and that all share the responsibility for care and the outcomes. To me, the solution or the improvement of the healthcare can happen by adopting first principle thinking. Thank you.
Well, thank you very much for that, Dr. Malik. That was a really good presentation. I like how you started off with the old-fashioned technology that was so big and so wonderful at the time, and then all of a sudden they narrowed it down and made it smarter, made it stronger, made it better, and by doing that, it was more efficient. First principle thinking. So thank you very much.
Thank you. Thank you, Carl. Thank you. Thank you for this opportunity.
Has anyone else got any questions? Chat box. Don't forget to use the chat box, guys, if you need to. Okay, well, if there is any other questions, just put them in the chat box and hopefully they'll get answered later. Thank you again, Dr. Malik.
Thank you.
Pleasure to meet you.
My pleasure as well.
Okay, so our next speaker is Miss Annette Van Ginkel from Saudi Arabia. Annette's completed her nursing education and administration degree in 2016. Currently working in a pediatric intensive care unit, PICU, in Saudi Arabia as a team leader. She has started her nursing career 35 years ago and has the following qualifications: general nursing care, midwife, medical and surgical science, critical care at the University of Pretoria, South Africa, medical and surgical science anesthesia. Also the qualification in preceptorship and mentoring, life and transformational coach, bereavement coach. She also does brain profiles that assist with team dynamics and team cohesion. I am passing the stage to her to deliver a speech. Are you there, Miss Annette? Oh, okay, she's left at the moment, so we just need to wait for her to come back. While we're waiting, there's something I want to read. So, this is about the UCG conferences. So, Utilitarian Conference Gathering offers a wide range of events, meetings, conferences, workshops, symposiums. We have a dedicated team who are aimed at acquiring the technologies, adopting the knowledge of business needs, and accelerate the best ideas and strategies. Utilitarian Conferences Gathering is a pioneer in the area of event management. Collaboration. We are a full service event provider specializing in the field of medical, clinical, healthcare, life sciences, engineering, pharma, environmental science, business, agricultural, and food event services for academic and industrial sectors. We stand out distinctively from our competitors for all our commitment to quality, round-the-clock service, and unmatched price. We are able to provide you with the best event meeting experience under one roof. We at Utilitarian Conference Gathering make sure that you as a client choose the most appropriate event. And thank you all for finding the time in your busy schedule to be here today. Today marks the major activity in the brief existence of the UCG conference, a moment where we are interacting, sharing experiences, amazing experiences, might I add, and reflecting on various areas. UCG 2021 is a remarkable event which brings together professors, researchers, and students in the field of healthcare, making the online conference a perfect platform to share experience, foster collaborations across industry and academia, and evaluate emerging technologies across the globe. We cordially welcome you to join us and witness the advances in the field together. The conference has attracted delegates who have come from all over the world, across the continents, and subject of the conference is surely of global importance. UCG thanks all individuals and organizations who have worked to make this conference a grand success. UCG Program Committee has put in long hours with many creative efforts. And finally, I would like to extend my appreciation to all the participants in this conference. There's been some great presentations. We hope you enjoy the conference and that our participation will contribute to our professional development and relationships. Hopefully I want to let everyone know that. So while we're waiting for Miss Annette, how is everyone doing?
Hi, Carl. How do you do?
Hi, Amal. How are you?
I'm fine, thank you. Thanks for joining us for the third time and sharing today with me.
I am grateful to be here, and I'm happy that I got to see so many different things, like the way that it's all come together and how many people have come here to share their experiences. It's just amazing, you know,
Yeah,
from different places and different organizations, and it all connects as well, which is quite remarkable.
Yeah, it's very nice. And we had also a very wonderful topics with great, excellent experience from our speakers.
Yes, definitely. Are you prepared for later?
I can't hear you. Can you repeat, please?
Are you prepared for later with the chairing?
Yeah, actually, I'm preparing and I'm ready for everything.
That's what I like to hear.
Thank you.
Bless you.
So I would like to remind everyone for some important points. First of all, I want to really appreciate all of you to join us for the third time in the third day for a healthcare, nursing, and patient safety conferences. Thanks, Carl, for sharing the first part of the today. Let me go fast on these important points. Speaker presentation time will be of 30 minutes. Keynote presentation time will be of 15 minutes. Questions and answers is allotted after the end of the session. There will be no questions or answers in between this speech. If you want to communicate, raise your hand or you can chat on the chat box. You can email us at any time if you have any issue or face any problem with your connection.
Thank you for sharing, Amal. What would I do without you?
Thank you.
So I've just had word that Miss Annette is back.
Hello, I am finally back, but now I need to get my presentation. So, but in a meeting, the other time I can actually talk about my presentation until I'm there. So yeah, we can start.
Excellent. Well, I mean, I've introduced you to the group.
Yeah.
So if you want to tell us a little bit about the presentation while you're uploading it.
Okay, my name is Annette van Ginkel. I'm originally from South Africa, and I'm in Saudi Arabia for the last 2 years. So yeah, interesting. I were here many years ago, and it was totally different from now. Things change, policies changed, the dynamics changed, everything actually changed. So yeah, and I'm very happy to be here. So my topic is actually healthcare workers and the pandemic. Why I chose this is because, yeah, we always want people to do patient safety, the best patient care, but it's not actually possible if you are not having the support. What I see at the moment is that a lot of staff is actually demotivated. A lot of them are not in. They actually not motivated. They're resigning. They are sick. They go to ED because they don't feel well. And before the pandemic happened, we actually went out, we had parties, we go to our families, we did a lot of things, and suddenly now we can't do it. I don't know about other people, but I am very much busy. I am always around, always doing things. And now I can't do it. I cannot go anywhere. And it is very, very hard to everybody. So I'm going to try to share my screen if I can get there. I'm still struggling to get onto my screen. Just ask somebody to come in out.
Yeah, it's been different with in the UK as well. Lots of
yeah,
lockdowns.
I need my stick. I need my sorry. It's there. It doesn't show yet, you see? It's not there. No, it's not local. It's sorry.
Do you need any assistance with sharing the screen?
No, you know what the problem is? It doesn't pick up on this on my stick on this computer. But what I want to also.
Have you tried pressing the green button at the bottom of the screen?
Yeah, but I can't screen because I don't have it on my desk. You see, this is what I see. I need to have the presentation on my stick. Okay, so what I want to say is we used to go away. We used to do things.
Sorry, Miss Annette, just if you would like, you could email the UCG team with the
presentation.
Yeah, and they can share it that way if it's easier.
Yeah, okay. I just want somebody just to come here again and help because it's not my computer.
Technology as well. I know what you mean. I struggle with technology the best of times.
But you know what? It's very difficult this last 2 days because I really struggle to go anywhere, and I'm not going to let this stress me out because I don't want to be stressed. So you see, I put it on another. I didn't put it on my desktop at work because I did my presentation at the other place, at my own computer. And here it's a little bit difficult according to policies on your own computer.
We get used to them, don't we? It's always different when we use a different computer.
Yeah, yeah. But I will just ask somebody to email it quickly. Just 2 seconds. Sophia?
Bless. If anyone else is having problems with their computers or their screens, just let the UCG know and they'll be able to help. Is this your presentation, Miss Annette?
No. No. Okay, what I want to say, they're going to email it to you now immediately. I work in a hospital in Saudi Arabia, in Riyadh, and it's not so big. It's like maybe 3-4 hours, 4 years open. But there's not a lot of patients. And the staff here is also a young group. Most of them are Filipinos. And also, they're very young. They're very young generation. And then we're also affiliated with Princess Noura University, where there's 48 female students, 48,000, sorry, female students. And they're very young. They're eager to learn. And with the pandemic, it's difficult for them to learn. Okay, they go to classes, that everything is on Zoom, everything is on their phones, and they are learning. But the big problem is, I ask questions, and I am more into wellness of staff because I'm also a life coach and I also are a brain coach. So if you look at your staff members in any circumstances, they've got coping mechanisms. And in normal circumstances, you can go out, you can go to the movies, you can visit your friends, you can have a big party. Now we can't. First thing, you have masks.
It's true. Things have changed. Things have changed. What we're gonna do, Miss Annette, we're just gonna share Miss Laura's poster on the screen so people can see it while you get yourself sorted and are able to email the UCG and all that, and you collaborate with them.
Okay.
Is that okay?
That is
so
wonderful.
Brilliant.
Yeah.
So we're just going to share Miss Laura's poster on the screen. Thank you, Miss Annette, and I look forward to your presentation shortly. Okay, so the poster is from Miss Laura from Spain, and it basically is patients needs registered by nurses in the autologous transplant. It's the Clinic Hospital in Barcelona, Spain. Introduction. Patients experience various side effects during high-dose chemotherapy and post-infusion with stem cell in hematological malignancies. If it is necessary, a great amount of nursing care. We believe that nursing registers should reflect all patients' needs as well as their complications in the best way as possible in order to establish nursing care interventions. The purpose: to evaluate nurses prioritizes on patients' needs during post-infusion transplantation. Methodology. Retrospective systematic revision on nursing annotations from 50 patients' clinical histories. Of the 50 patients included in the study, 62% males and 32% female. Mean age 47 years, range 18 to 65 years. 42% of NHL, 20% multiple myeloma, Hodgkin disease, and AML. Born with 12% was variant statistic analysis on the following variables: fever, mouth problems, problems in elimination, problems in nutrition, anxiety, catheter infection, and mobility. Results: 36 patients show fever in the first week, with the highest prevalence in day +6 post-infusion, as well as 4 catheter-related infections in patients. Nutrition problems: anorexia was present in 54% of patients, mostly in days 0 to +4, and nausea was present in 2%. Mucositis was registered in 56% in days 0 to +, with pain most present in days +5 to +9. There is a pattern. Anxiety registered in 50%, but only 3 with psychiatric severe disturbance. Activity intolerance of 20%. Conclusions: main needs registered by nurses are fever, pain, mucositis, fluid retention, diarrhea, and parenteral nutrition support or vomiting. But anxiety or psychological needs, as well as mobility or sleeping problems, are not registered. On the basis of the result of the study, in the future, we will introduce a greater systematization in collection of data concerning to patient needs with an standardized work system, and nurses should focus on continuous staff training, and we should address professional actuation to nursing diagnosis. That's very interesting. Thank you for sharing that, Miss Laura. And Miss Annette, I've heard that your presentation is now ready.
Yes.
Excellent. We always get there in the end. Persistence is key, Miss Annette. Persistence is key, you know.
Yes. And especially if it's not your own computer.
Yes. So it's started to share now, which is good. So you have the stage now, Miss Annette. It's all yours.
Oh, okay. Okay, like I said, I'm Annette van Ginkel, and I'm in Riyadh. And I'm actually enjoying it here, but I also need to say to you that I learned a lot, especially because of the millennials. So I'm here because of the millennials. Okay, we can go to the next slide. This is the hospital I'm working. This is at night. And it's actually a great place, but it's still a very young hospital. Next one. Can we have the next slide? Okay, this is the half of the team. And as you can see, it's very young people and it's great people. And most are Filipinos. There's 1 Malaysian, 3 South Africans, and Egyptians, and Saudis, and 1 from India. And we are a great team. I must say, our team all support each other a lot. And that is what we're all about. Next one. Okay. Who is healthcare workers? So we always say doctors and nurses. But actually doctors and nurses are only a few of the people that is healthcare workers. What about the physiotherapist, the pharmacist, the speech therapist, and the respiratory therapist? And then there's a lot of other people that is actually part of our group. But the people who are the most in the back of us, and it's actually our force. It's housekeeping, because without housekeeping, we cannot do anything. Maintenance staff, waste removal staff, delivery staff, people that's working in the kitchen. Without them, we actually can't do what we do. You know, patients are happy with the medication we give them, but if they have a warm plate of food and they actually have a clean room, they're actually fairly happy. We try to do the best we can, but we are not the most important. Yes, we do the medication, we do the normal care, but the other people are just as important. And I must say, in the pandemic, these people actually shine, because without them, we can't do it. Next slide. There's a lot of studies. I must say, I was looking through a lot of things, and then they talk about mental health of healthcare workers in the COVID, the critical role of healthcare professionals during COVID-19 pandemic, and then they talk a lot about mental health. And if you listen to the news and you see what's internationally, is that the frontline staff, the people working with COVID, actually has a lot of strain, has a lot of issues, because people are dying. Healthcare workers, if I look in my own country, healthcare workers are now at the forefront in patients that are dying, and that's complicated. Although, if I look at Saudi, yes, the cases are picking up a little bit more, but healthcare workers don't get so sick, because I must say Saudi does do a lot. They really do a lot in PPEs and in training and in support. I'm very happy to hear about Prince Sultan, what they actually do in their COVID project. They actually have a special place. Their staff are in a different building. They have internet and all those things, and that counts for staff. Not like where you work with COVID patients, and if you're not happy, you can go home. And a lot of staff, this is their big problem. Next slide. What is happening currently? Loss of income and compensation, because if you are sick, you don't get paid. If you a lot of places actually close down. People lose their jobs. People are more ill. People are more mentally ill. And with poverty, or with there's no food, you can't eat well. Your immunity are low. Loss of family and support. If I look at nursing, and especially expats that have single contracts, their family is far. Some people actually saw their family 2-3 years lost. And how do you say to your 2-year-old, sorry, mommy can't visit? It's very, very hard on the staff, especially the younger ones. Limited family life. Yes, if your family are with you, you are so privileged and so blessed, because you can actually hack your family member and say, oh, please just hack me, I need some support. What we also see is a lot of suicide in healthcare workers, because suddenly they feel overwhelmed, they feel that they're scared. They're scared the whole time. Dying healthcare workers, work-life balance. We can't even go out. You're even too scared to go to the shops, because who is there? And also, if you work with COVID patients, you also don't want to mingle a lot, because of you're scared that you can give it to other people. Burnout and stress. Yeah. If you ever wear a hoodie and for 12 hours an N95 mask, and then your yellow gown, and a little head cover and shoes and all those things, you know what we're talking about. It's not easy on healthcare workers. And also relationships. People tend to be more, some people are depressed, some people are fighting, some people don't even want to talk to you because they are so overburdened. And if you look at cultures, some people won't talk. If you look at Filipino nurses, they will smile. You won't even know that there's something wrong with them. And we tend to forget that even if people smile, they might not be okay. Next one. I ask a lot of people, what makes you scared now? I just ask this question, what makes you scared? People saying, I'm scared that I'm dying. I also scared that my family member are dying. Never see my family, losing my job. I've got losing my job somewhere twice. Suicide. There is people that say, you know what, I don't even want to live in this time because I am more scared than something else. And there is no life for me. And some people are lonely. And that is the biggest thing, is loneliness. We are human beings. We are social human beings. If we say our patients are social, physical, emotional, spiritual, we are also like that. It's not just our patients. Next slide. Mental issues of healthcare workers, a lot of them are depressed. And you know, mental issues is actually a problem because there's always a stigma. There's a stigma. But if you think that you're having mental issues, what about your family? Sometimes your family will say, please don't hug me. Please don't come with your uniform at home because we're scared that you're going to give us COVID. And also, we're scared also that we're going to give them COVID. We're anxious because you're working day after day with COVID patients. You see patients complicating in front of your eyes. Yeah, not everyone die, not everyone complicates, but a lot of them do. And what do? You're anxious because what if I do something, or what if I can't save my patients? Some people withdraw, that's just a coping mechanism. Some people fight and they're in conflict because inside them they have a lot of conflict. Sense of isolation because now you must wear a mask. You cannot go anywhere. There's lockdown here, lockdown there. You can't go to your family because the airports are closed. And there's nothing you can do about it. Feeling of despair. I'm just tired. I don't know what to do. I don't have any answers. I will just leave it. And nurses and also other like doctors, we always want to help people. It's so nice if your patient gets better. And when you are like that, you might have a situation where you don't have empathy. Nobody looks after me. Why must I look after somebody else's mental illness or issues or their health? Because nobody looks after me. I'm not okay. And we can't verbalize, because if you're not okay, then you are weak. It's not a sign of weakness if you say, I'm not okay. Next one. Physical issues, increased sick leave. What I saw is that people will go and say, I've got flu, I've got a sore throat, I've got a headache, I can't smell. Because after you did your swab, you can have 2 days off. And that is a reality because they are burnt out. Weight gain because you don't have time to eat. So, and you also don't sleep well. So what you can get, you will eat. And it's not always healthy food. Or you don't eat, loss of weight. You don't have time to cook. You don't have time to eat. Hypertension, increase of use of habit-forming substances. And also you have body aches. You have pains where you'd never know that there is a place. You have pains. And what are you going to do with that pain? You take anti-inflammatory, it's not working, you're taking something else. Maybe you have a headache and all that you actually need is water. But there's no time to drink water. You just need to go on. And if you go on like you're depressed, you don't eat well, you don't do exercise, you don't have energy, you can't cope anymore. There's no energy anymore. Another one? Sorry. What can leaders do? If you watch New Amsterdam, what's very, very remarkable, that doctor, the CEO of the hospital, always say, what can I do for you? Do the leaders ever go to the unit and just go around? Don't go look for dust. Don't go look for clutter. Don't look for any faults. Just go there and ask the staff, how are you? Are you okay? What can I do for you? We don't want food. We don't want extra things. All what we want to see people that they really care about you. So the support they need, the staff needs it. Wellness programs. There's a lot of literature about wellness programs. But what I found is that if there was a wellness program, it actually is not functioning anymore because everybody focused only on COVID, on PPEs, on swabs, on vaccinations. But there is not a wellness programs actually running at the moment. Wellness events, wellness rounds. If the leaders go and do a round and just say thank you to the staff and not say to them, if you don't like it, go home. Because this is not what they want to hear. They want to work, but they're exhausted. There's services. What you can have is like counseling services. Is there resources for them where they can phone and say, I don't cope, please just help me. Recognition. A lot of our staff, they enjoy recognition. Just a thank you, that is fine. Incentives. Yes, other hospitals will say, oh, but we got COVID money. And people really say, oh, we're going to get COVID money. So it just keeps them alive or supported. But then the COVID money is not arriving. So they say, oh, then I'm not going to work. I'm not going to work so hard. Time off. When they spoke to us like Prince Sultan Hospital, what's very important, what was very interesting is that the people work 8 hours and they 24 hours off. I must say, wow, because that is really great. Imagine you are off for 24 hours and you only work 8 hours. You can rest, you can eat, and you actually feel people are actually caring. Vaccination campaigns, this I must say, Saudi is very good in that. We did get it, and it's just you that need to register and you need to get it. And it does give you a little bit of okay, people are looking after me. Take care of your staff. So leaders must take care of their staff. That is most important. Environment of open communication. Open communication is very, very important, that I can say, sorry, I can't cope. Please just sit here by my patient while I'm doing something else, or I just go and eat, or I just go and breathe somewhere. I think this is important, and that it would be very interesting to go to Prince Sultan and actually see what they're doing. It will be, for me, it will be wonderful. Another slide. What can I do? Meditation. You know, if I am overwhelmed, I just breathe. Even if my eyes are open, I breathe, but I want to hear my breathing. I just focus on my breathing, because sometimes it happens in the unit. You ventilate people, everybody's running, you're trying to get PPEs, you're trying to get medication, and then something is not working. And sometimes you just need to stand a little bit behind and say, just 2 seconds, just give me a chance just to get my breath. Group debriefing sessions. I think we don't debrief. We don't put a lot of emphasis in debriefing. Just to say, how did you feel? Already you feel that somebody is, thinking that you are important. In our unit, I'm working in PEDS ICU. We've got our chairman is a doctor, and why? He is so good. You know, he will ask us, how do you feel? What can we do better? I think we need to do training in this. We can do it. And if somebody just debrief, we feel that somebody listens. Social gatherings in small groups. We do know that we're not allowed to go in big groups. So small groups, it's fine. Just come let us have a meal together. Let us have coffee together. At least we can talk. Healthy eating? Yeah, you can do that. But I feel that we That is one of the things that we don't do. Rest and sleep. Some people sleep too much, other people don't sleep. And sometimes you wake up at night, and what are you doing first? You're on your Facebook. And this is the thing, sometimes you just need to close your Facebook. Exercise. Yeah, we don't do it. The gyms are closed. And also, you don't have the facilities where you stay to exercise. I also want to say that it's important to say today, I don't feel well. Please, I'm not angry. I just don't feel well. So people can know that you're a little bit vulnerable today. Intentionally employ coping strategies. Everybody is different. If you look at the different type of personalities, some people want you to talk to them the whole time. Other people want facts. Other people want lists. Other people say, just don't talk to me. I'm okay. I'm fine. They're okay. What I found is reflect about things. It's important because I can say, okay, this happened today. How can I make it better? What did I do wrong? And what I learned to do is to go back to present. Say I shouted at somebody. To go back and say, you know what? Actually, I was wrong. Let us just see what we can do from now on. Take breaks from social media and news and negative people. How many times did we hear people, COVID is not, it's the government who's actually want to control us. I am not going to do the vaccination because they're going to put chips in us and they will know where we are. Of course I know where we are because we are on all types of apps. Does it really bother me if anybody knows where I am? But put your phone off, put it on silent, not only on vibration, because if it vibrates, then you wake up and then you tend to be nosy and you want to know what's happening. And also remember your goals. Why are you where you are? I am here to work towards my goals, but other person's goals are different. So, and let them achieve their goals. Yes, we are all anxious. We are all scared. But remember your goals while you are here, while you are having a tough time. Next slide. Lastly, if healthcare staff are content and feel supported, they will be able to deliver safe patient care. And that is what we want to do. We really, that is also staff. If you look at the next slide, we always want a party. This is, we have faces, we always want to eat, and we are laughing. And this is important. This is putting us together. If we have goals, if we have things to do, we do it together. And if your staff is smiling, they're happy, they feel content, they will do much more for your patients to be happy and safe and also content. But if you don't feel well, you feel overwhelmed, you feel depressed, you feel tired, you're not going to do more. I think that the workplace can do much more for their staff. But I think also staff needs to tell what you need, and everybody needs something different from the next person. And if you see healthcare workers, they eat. Thank you. You can ask questions if you want to.
Well, thank you very much for sharing that, Annette. That was a good presentation. It really brought home what's happening around the world at the moment and how it's having an impact on healthcare professionals and in the healthcare settings. And it also brought to light that unity is so important, you know, under these circumstances. Working together and being on the same page to promote recovery and well-being of oneself and our colleagues.
Yeah, you know what I want to say is that I am more mature than a lot of the younger ones. So they on their phones the whole time. So you come and say, why are you on your phone? Hello, why not? Because I realize if you're on your phone and you play a game, actually you relax. I never could understand it because my child is their age. Now I come there and just find fault. And what I also realized, I needed to change. Not them, I need to change. And I need to say, I embrace your youngness. I embrace everything that you are about. Teach me also certain things. And if you change, everybody around you change. And don't always shout. Don't always see what other people is also going through. Before you say, you're useless, you don't know what you're doing, don't do it. Because all of us are stressed.
You never know what anyone else is going through, do you, really, until you speak to people and try and get to know them a bit more and support them the best way possible.
Yeah.
But also, I think it's important to reflect on one's actions as well, you know, just to try and find what went right, what went wrong, how can we make this better?
Yes. This is new for everybody, isn't it? It's new for everybody. Everybody went into a thing and we don't know what we're actually going through. We don't know what hit us. And we are social. We want to party. We want to go out. We want to shop. We want to eat. Now we can't.
Yes, exactly. I totally agree. Has anyone got any questions? Okay.
Thank you.
Well, if there is any other questions, just put them on the chat box. And Mr. Net, thanks again for a great presentation.
Thanks a lot. Thank you. Bye-bye.
Bye.
Bye-bye.
Okay, so now I'm going to hand over to Amal. So I wish you all the best of luck, and I have every faith.
Okay, first of all, I would like to thank Mr. Carl for sharing the first part of the day, and Ms. Annette for this wonderful, informative topic. Now, the question that we have all in our head is, what is safety in ICU? Because the question is what our next presentation is going to answer to with Dr. George from Belize. So let me introduce Dr. George Courtland. Dr. George is a professor of critical care, former head and co-founder of the Division of Critical Care at Memorial Hospital in Belize, Central America. He's also the co-founder of the Intensive Care and COVID-19 Unit at Belize Healthcare Partners, Federation of Societies of Critical Care and Intensive Care Medicine, awarded with the highest recognition the American College of Physicians offers to his members in 2012, Master of the American College of Physicians. So, Dr. George, we are welcoming you to present your topic on the third day. I'm passing him the stage to deliver the keynote speech.
Thank you, and it's an honor to be with you guys in this third day of an important session. Just before I start,
George, can you hear me?
Yes, I can hear you. Can you hear me?
Yeah, I can hear you. You can start.
Okay. Just before I start, I send you my presentation. I'm not in my office right now. Are you able to put the presentation for me? Hello? Can you hear me? Can you hear me? Can you guys hear me?
Yeah, we can hear you. We can hear you.
Okay, thank you.
And the presentation's up now.
Excellent. Well, in the next few minutes, we will try to share with you guys some of the aspects of safety, and probably one of the most important aspects of safety in the many ways we can approach the safety is either see what is happening in our facilities, patients, nursing, doctor, but probably one of the most important aspects is what is the voice of the patient. I mean that I am Dr. Jorge Hidalgo. I'm an intensivist and also an internist, and actually work at Belize Healthcare Partners in Belize, Central America, and also I am the Secretary General of the World Federation of Intensive Care Medicine. And as I mentioned at the beginning, I just want to thank you, the organizing committee, to put these excellent sessions, and I personally have been enjoying some of them. I've been unable to connect all the time, but I'm trying to be connected and enjoying most of them. I mean that saying that, if you give me the next slide. I don't have no conflict of interest with this presentation. No. The next. I mean that as we start saying, for the essentially understanding the patient voice is a critical goal for us as healthcare providers, seek and trying to listen the voice of the patient and trying to integrate what the patients are needed, what they want, and integrate it to how we are going to put all this information to deliver a good healthcare. At the end of the day, one of our main goals is to try to offer the patients a better outcomes. I mean that in that case, we need to say what is the patient need, what we need to listen to them, trying to encompassing what they want and also the different challenge, particularly trying to agree on the different ways we can approach that. I mean that, and it's important for us because we need to have some way how we can measure it and how we are going to capture the patient voice, how to address that. In that capturing the patient voice is definitely a center, or should be a center of our what practice of medicine do. And most of the times that is not a very difficult or not easy task. No, it's a difficult task. But there are many ways how we can do that, and then that's the intention of the conversation today. I mean that we're trying to move away from free for service models to trying to empowering the patient voice. We will need to try to integrate social determinants of the health of the patient to give value to what exactly we are planning. And important thing is we need to improve collaboration, including the care team, the documentation team, to carry the patient voice through a continuum care, adapting healthcare access to align with patients' needs, and updating medical training to include the importance of the patient empowerment. I mean, those are the things that we definitely need to focus when we are trying to capture the patient voice. Next. In that the patient voice adds a different perspective of everything. Patients are most of the time say that are the center of the healthcare, but most of the time the voices are ignored or put aside in the decision process, no? Especially when it comes to health, treatment plans, the cost of the care. The care is definitely should be a patient-centric. No? However, is something that we're still fighting to trying to do so. Of course, as we know, there are many systems, and each systems need to adapt based on individual needs. I mean that probably the needs for a health system like in my country is not exactly the same as the need for the health system in the different countries you are. I mean that we need to be able to adapt, and we need to be able to see what exactly is needed in my setting, and to be able to put things in perspective. The patient voice has different perspective to everything that goes on in a healthcare system. In that amplifying the patient voice is important, and definitely it requires that our organizations get into it. This can just be one separate effort. If the patient voice is not included in our organizations, in the process system, then it's definitely very challenged. The next slide. I mean that one of the important things is that we need to be able to create or have the ability to work on different type of efforts, different type of reports, with the intention to measure, as an example to create. We need to be able to collect data, to collect information. That is definitely a very important key part in order for us to be able to capture and to, in a way, trying to see how we can include the patients as part of the making decision process. I mean that despite of everything, patients report outcome measure is important, but it's something that definitely not all of our organizations are doing. We need to be able to document that, to create all this data for in the best interest of our patients. I mean that making the patient voice as the centerpiece of the organization business models can sometimes result in a power shift. I mean that as we know, we need to be able to see how we can add our organizations to do so. And part of the reasons that the patient don't have the voice is because most of the time we tend to medicalize, and consequently we have the tendency to take over everything around certain activities. And I mean, sometimes we need to make the patient responsible for the outcomes at the end. And the other important aspect in that essentially influence the way we practice medicine those days is the liability. Definitely, liability has driven situation where all of the activities surrounded the patients. I mean that we need to thinking on the different type of protocols, what are institution responsibilities, what are the clinician responsibilities. I mean, liability is definitely something that in a way it make difficult for us to definitely focus on that, but that's why we need to make all the effort to trying to capture that, to trying to have the different data is needed to be able to put in place what are the needs of the patient. Everything from calling a patient for a test results, offering referrals for a healthcare services, such as if we want to refer a patient to the physical therapist, or referring the patient to nutritionist, needs to go to a process because everything needs to be documented. No? I mean that essentially is something that we need to be creative, systematically transfer more power and responsibility to patients, with the idea to empower the voices. No? The next slide. I mean that the other important aspect is definitely how the payment models can essentially interfere with the voice of the patients. No, we need to figure it out how to remain viable in our institutions, and of course trying to generate enough revenue to keep the lights on, and also to keep our staff pay, while we will spend more money in trying to know our patients and get them involved. No? I mean that it's something that definitely we need to work on, managing a largely population of, as an example of patients, and elderly population, with definitely, as we know, most of the time, as we are the aging implies that there is more resources needed. Most of the time, patients in an aging are polymedicated with different other group of needs that we need to contemplate. I mean that there are several models that it can be applied. One should be a volume-based model, suggesting that if the patient do poorly, the health system may probably do better. We need to run more tests, trying to create more data, and see exactly how the system can improve to offer patients a better service, and also a center care for patients. No? I mean that it's definitely a deep desire in healthcare right now, as we say, how we are going to put patients' voice as the center, no? if possible. However, all the time, our main focus is for them. No, is essentially an organizational thing, as see how we can offer that. No, when it's just the physician and patient, when the patient is the center of the discussion, we need to work together. No, is trying to offer them the best we can, and trying to adapt our different systems of the way we practice to essentially focus on them. I mean that the universal access could be a cost-effective and clinically effective way to alleviate some of those. No, I mean that that's definitely the important, that we need to generate more data, no, to see everyday practice, and see what is the different steps or the different actions measured that we need to take to be able to focus to be able to empower and give our patients the necessary voice. The next. I mean that sometimes our systems can be complex, no, and face that we don't take the time to pass and to understand our patients enough. No? mean that we need to try to look for those opportunities to try to embrace and to be able to see what recommendations are needed, and that we can offer the different choices in order to essentially empower our patients and trying to definitely give them the opportunity to get more strong, and also, as we mentioned, to be able to empower them. And then in that regards, there are many things that we can do. We essentially say we need to discuss the design of care. Not too often, the healthcare system has designed patients' care around the needs of providers and around of infrastructure, particularly high cost fixed infrastructure. No? This is something that we see in industries where resources are centralized, specialized, and also over capacity, but it's an unsustainable type of healthcare. No, I mean that the design of care must be ultimately a center for our patients. No, the patient-centered design should play a leading role in designing all aspects of healthcare, from the physical spaces, the workflow, the communication templates, provider systems, and payer, to have a perspective and assume knowledge of the patient's perspective that sometimes could be incorrect. No? I mean that we need to try to incorporate patient voice in the design of systems of care, quality of care. No? I mean that is an important and a co-production of care as an important as the patient voice is in the system, is equally important the care of each individual. No? Treating patient is definitely a key part. I mean that there are numerous ways in which we as a provider should definitely consider an individual patient voice as an input, as a variable to decide how we are going to deliver the care. And definitely all these different aspects need to be put in a data collection system. No? We need to have in consideration aspects like the goals, values, preferences. All patients are not the same. No? We know that the needs are individual, and even in the case of the same diagnosis, the patients behave in a different way. No? There are differences in what individual patients want out in their care, what is important to them along the way, how they want to be treated, trying to achieve a good result without understanding how patients defines good. It requires an assumption that we definitely need to think about. I mean that, as mentioned, the needs are different. No? I mean that is something that we need to have in consideration and trying to empower our systems in that regard. No? The next slide. I mean that that's definitely the clinical decision present process, the context of the psychosocial environment. I mean that those are aspects that definitely we need to have in mind. No? We need to be able to see all these aspects when we are making decisions. No? We need to have in consideration what are the psychosocial environment of the patient, what the patient is going through. No? Mean that is some of the aspects that we need to have in consideration. Mean that just to give you an idea, if an inpatient have an external incision, has poor mobility, and lives on the second floor, and there are no elevators, mean that we need to have that in mind as team care, no? As part of the discharge process, how we are going to advocate to trying to see how we can arrange these patients, no? The way the patient would have if they don't have, because probably the patient is going to be unable to use the stairs. No, I mean that we need to be able to see how we are going to accommodate the needs of our particular scenarios. No, I mean that and trying to amplify what is required. No, I mean that we need to have definitely a patient engagement. How much a patient is willing and able to take in a new information, in a great pool of realities of care, no? Treatment tactics or strategies to essentially engage the patient's conversations. Mean that is the patient engagement is an important precondition for patient's activation. What is needed, the knowledge of the patients, I mean that is key, no? And of course, with everything also we need to be able to see how we're going to collect the data, no? The biometric data that it will help us at the end of the day to provide a most centered patient care. No? The next slide. I mean that as a healthcare professionals, definitely one of the things also that we need to have in mind is what are the social determinants that we are going to use. No? The social aspects that is definitely it will back up our systems. Definitely is definitely an important, and especially, as I say, we have different environments, different social aspects, definitely different ways how we are going to approach the system. But we need to probably ask the questions and be comfortable asking questions in terms of what are the difficulties lying in a patient to be able to successful run treatment at home. What are the challenges they have in a different scenarios for a mother, for as a son, or for someone to take care of the loved ones at home, the access of care. No? Sometimes depends on the environment, is not easable, or it's not with the institutions are not accessible, or depends on the needs of different circumstances. It's difficult to access properly care. No? I mean that the social determinants definitely is an important aspect that we need to have in mind, because of course is definitely a critical part. No? We need to see how those are going to affect the outcome of care. No? Healthcare commonly measure her outcomes like mortality, but some outcomes like that matters the most, like the social aspect, is something that we need to be able to measure. No? We need to see what are the challenges for the patients. No? We need to be able to collect those data and see what is the patient experience. No? In addition to the length of the quality of life, an important outcome is what is the peace of mind when a care episode is over. It matters to patients whether they feel confidence that all that should be done, were done independent of the outcomes. Confidence is built through a good communication, as we was talking yesterday in the leadership. Trust is important, and trust is something that we need to build in this continuous relationship as in the healthcare with patients. No, confidence, a sense of teamwork among providers, and make the patient feel that they are the most important person in our system. Patient satisfaction, how we are going to measure that. The next slide, please. And the other important thing is pain is probably the great example of how we also need to manage the over medicalized system. No, there are definitely the control of the pain for the patient is a great example of that. No, simple things like using a scale to describe pain is important, especially in a different setting. Probably in an inpatient setting, those aspects are very covered, but in an outpatient setting, how we are going to measure those aspects is a more complex problem. No, but we need to be able to see how we are going to alleviate the pain, no? And how we are going to manage. No, people just want to feel that they can function and that they can be integrated to their regular life. They want to definitely continue to be productive, and then we need to give them all the necessary elements to that. No, I mean that as we know, unfortunately, the chronic pain is have a multifactorial approach, and also multifactorial causes, and then we need to be able to see how we can help patients to accommodate and to manage these important aspects. No, patient satisfaction, how we are going to measure that, how well the healthcare meets the patient expectation in this and to offer confidence as what we are doing. Definitely include what the waiting time, amenities, the process of receiving care, how the patient felt along the journey we are doing. No? And again, it's important that we have patients reported outcomes measures, especially when we're talking about pain. No? Trying to validate, quantify symptoms, the physical function, the mental health, and quality of life. You know, quantify symptoms and functions. It will allow us as a providers to definitely to augment the history-taking process with a reliable and numerical measure to determine the most appropriate intervention. The patient needs, health-related social needs, social determinants of health are definitely important, because they will contribute as how we are going to address. No, trying to treat medical conditions without considering the context of these needs is definitely difficult. No, the informational needs, the language, the preferred communication, the health literacy, the knowledge. We need to know that at the moment we are prescribing something. We need to know if the patient is definitely understanding what we are doing. People consume information in multiple different ways, no? And have different preference for formats and channels, such as text message, phone calls, written letters. No, we are living now in a different age of communication, age of social media, in a paperless age, we can say that we want to use less paper those days. No, I mean that it's crucial for us that we need to accomplish all those different measures and trying to see what are how our patients are engaging or are involved in this aspect of technology, you know? Especially the elderly population. Our younger population, they are it's probably more simple for them. But how we are going to have this conversation with an elderly patient, how we are going to accommodate prescriptions, how we are going to facilitate for them to access the different needs that they have. I mean that we need to. That's why we need to individualize the care. No? The next slide. I mean that how can I make a note when there are 10 different needs? No, like the American health system, no, electronic records, and then trying to make the lives difficult, and at the end of the day, probably who will suffer are the patients. How we are going to manage that part definitely is not an easy way. But as I say, each system have their own challenges. Each system have its own social determinants that we need to definitely gravitate, and if we need to document properly and trying to message back to patients as essentially how we are going to improve, no? Making feel that they are the most important in our system, no? In that that's are the different aspects that we need to integrate when we are tracking patients' goals, patients' priorities, because probably the priority for us are not the same. The barriers to stay healthy, you know, what are the barriers that we need to document what is happening, and then with all this data, then trying to standardize based on what are the needs that we have for again for our different system, because as mentioned is definitely something that is different for everyone. I mean that healthcare providers, they invest enormous time and money trying to capture the patient voice with different systems, no? But most important is that we need to get all those to work for them. We need to be trying to prevent this chaos and trying to definitely integrate what those different measures and capturing information, how is going to be applicable to our daily function on patients, no? I mean that and transparency is important, no? We need to be able to be transparent. We need to be essentially be credible and basically influence the systems as trying to put the patients as a one priority. No? The next slide. I mean that and as we mentioned, we are in an age of communication. Information is definitely that the information we got from the patients is like a fuel. No, we need to definitely see how this information can we put into work. No, I mean that we need to be able to see how the information we got is something that we can put to work in our patients. And as we discussed previously, we are living in a times of communication, in a time of social media, and we need to see how that can be applicable to the different needs of the patients, and of course the different groups of age, how we're going to individualize, how we're going to make that systems or the different tools that we have now, and how we are going to put all these different tools to work in the benefit of our patients, how we are going to do that, take advantage of the different tools we have to trying to essentially apply, listen what the patients need, and put all those to work together, no, for the benefit of our patients, no. I mean that all this definitely how we're going to apply the communication, the systems into the design of care that we already mentioned, how we're going to apply the system, the social communication, the social networks to a patient-centered design care, how we're going to use the new ways of communications to the production for care, for individual design, for patient engagement, for our goals, values, preference. I mean that those are the different questions we have, no? Or we need to answer, and we need information to put together. And of course, having the social media is probably something that we need to optimize in the sense as measure data and measure patient experience, trying to collect the report and to collect those data. No? The next slide. I mean that that's probably one of the most key points. How we are going to educate our next generation of medical professionals about the patient voice. I mean that we need to try to keep that in mind. We need to, with all the different aspects we discussed already, we need to be able to educate our new medical professionals in all fields as have as how to listen the patient voice, but also to make the system also to get into it, to make sure that they understand all in the design of care, patient-centered care design, patient and family advocacy, co-production of care, the how we're going to be able to make sure that our new generation go into the input of care, patient goals, the values, preference, patients engagement, activation, collect biometric data, sensor, how we're going to collect the outcomes, patient needs, health related social needs, information needed, language preferences, communication, health literacy, knowledge, social isolation, the collection of the data, no? the specifically data as the outcome measure reports, symptoms, how we're going to collect the symptoms, the physical function, the mental and social health, the quality of life, the patient experience, the confidence, the trust, it's a peace of mind, patient satisfaction, how did the process of care compare with what are the expectations, what expectations the patient had at the moment of being admitted, and then what are the outcomes. I mean that trying to integrate that and trying to get our new generation of people getting to that is a critical part. No, the next slide. I mean that is as I say, you know, the education is important, we resisted to use virtual care for a better part of a decade, and yet we are able as an industry to pivot and deliver nearly 100% virtual care in only a few days when it's something that suits us. I mean that, and especially in the days of that, you know, the days we are living of COVID-19, the technology is something that we are essentially using more, you know, the ability to have a virtual consultation. And then that's the some of the things, you know, how the different patients are feeling about having a virtual consultation, the ability to be able to have a virtual consultation. Probably one of the younger generation, they are going to be able and easily to get into a computer and to get into a console. But what about our elderly patients? What about the population that they are not also so fortunate and they don't have access to computers, that is still in some of the our realities around the world? No? I mean that it's a complex situation, but we need to easily trying to adapt and see how we can solve all those different issues. No, the next slide. I mean that the definitely, as we mentioned, no, the COVID-19 changed access to the patient voice, no. But and as we mentioned, the example, no, of course, we forced to use the different social and online resources, and slowly we need to see how our institution can starting to recognize the real power in listening to the patient. The patient voice is getting louder all the time and being brought in more and more conversation. No? I mean that that definitely is critical. We need to be able to collect that and also to know exactly the needs, the individual and particular needs, not only for the patient, but also to our systems, and how those two important players can integrate. Next slide. I mean that in conclusion, as we discussed from the beginning, the main idea is to try to summarize is that we need to try to collect what is important for our patients. There are different models that go for fee for service, and probably is not the best model. As we mentioned at the beginning, each system and each health system definitely needs to see what are the best way for them, you know? The best system, what is working for this country probably is not the best way for this other country. We need to be able to integrate the social determinants of health and patients' values into the care. Know what are the social environment, what are the needs that you are facing the most, and trying to improve collaboration, including a care team documentation to carry the patient voice through the continuum of care. No? Care is a continuum process. The care doesn't finalize when we discharge a patient. The patient, the care continues, and we need to document what happened before, during, and after admission. No? adapting the healthcare access aligned with the patient's needs, and updating medical training to include the importance of the patient empowerment. I mean that those are the different aspects that we need to have in mind, and that we need to consider in the patients. I mean that then at the end we need to ask us the questions why we are going to measure improving patient experience as a minimum priority of organization. Is that important? How effective is our organizations in delivering patients feedback or data to make systemic improvements on care delivery? Measuring and improving patient experience have an intangible return in our investment. And the questions that we need to ask ourselves: what are the top 3 most important aspects on capturing the patient voice? The barriers that we face as a system. I mean that what are the reports we are getting? What are the barriers we are also facing on collecting those reports? I mean that those are the different aspects that I decided to cover today, and hope I give you guys some inputs or some important messages to take home. And the next slide. And thank you again for this wonderful gathering and this important meeting, where we have the opportunity to essentially exchange ideas and promote discussion in the healthcare system, how to be managed. And with that, also want to invite you to attend the World Congress of Critical Care that is going to be virtual, September 11 to the 15 in Vancouver, Canada. Thank you very much.
Well, thank you, Dr. George, for this informative topic. Actually, I would like to ask if there is any questions for Dr. George. Please, if anyone has any question, you can type it in the chat box. Actually, I have 2 questions for you, Dr. George. I will start with the first one.
Yes.
What are the major differences in the ICU admission during the first and second COVID-19 wave?
The difference in admissions for COVID-19?
Yeah.
In our ICU?
Yes.
Okay. Can you hear me?
Yes, now I can hear you.
Okay. As I'm saying that the way how we approach the pandemic, and I believe all of you guys are going to agree with me, at the very beginning is definitely has a lot of uncertainty. The way we face the pandemic, we face something that were really new to us. I mean that most of our ICU were very overwhelming, and also facing the high mortality that we faced at the beginning, because of we were in a process to know more about the COVID-19. At the beginning was very challenging, not because now it's not challenged, but now we have some more information, and we can make decisions, and we can in a better way. Our systems are more integrated. At the very beginning, we essentially need to rely probably in only one center. But now I believe, as most of you have a very stratified ways as how to deal with the level of patients, depends on the severity. I mean, that is more easy now than at the beginning, because at the beginning was overwhelming for all our systems. But now we also have the opportunity to allocate resources to all the different hospitals, and also to we already invest, as many of you, in training.
Okay, that's great. The second question is, nurses on the front line against the COVID-19 patients, which are the main isolation and triaging issues you did in your clinical practice? My question refers to the issue that the nurses face when they are caring for patients with COVID-19 on isolation protocols, and which triaging methods you use in your medical facilities.
Yeah, well, as we know, the frontline health workers, and especially nurses that and facing COVID-19, it put a lot on them at the beginning, and still, but of course at the very beginning, the uncertainty as what is going to happen with them, of course the resources, the use of PPEs at the beginning, lack of PPEs, because if you remember, in the initial months of the pandemic, was a lot of need for PPEs and also lacking of PPEs. Now, of course, we know more, and probably it changed a lot the way we are doing it. But at the very beginning, we were afraid, and also as one of the things, as we mentioned, and I believe all of you guys are being mentioned and listening into the different conversations, is that one of the key as us as an institution is to trying to making sure that our frontline workers are well protected. And when I say well protected, I am not referring only to provide them with a PPE, because this is probably the more easy thing. What is important is what we are going to do with our nurses and frontline workers in terms of making sure that they are mentally health, mental health, what are the needs they have are being provided, what in terms of security, in terms of mental health, and of course in terms of what the revenue, how we can make them feel that they are important and they feel secure, and that we as a system are for them and thinking of them and working in the best interest for them.
Great. My last question for you is, what's your practice of sedation in COVID-19 ICU patients?
The preference of sedation, that's a very important question. As you remember, before the pandemic and before COVID-19, all of us as managing patients in the ICU, we were entering in a phase of less sedation and less muscle relaxant. Now we came the COVID-19 period, where then we start again using heavy sedation and also muscle relaxants, patients with a lot of days admitted in the ICU. I mean that the different phases we've been through during the pandemic. At the very beginning, patients spending a lot of months in the ICU because we were in the process to understand the condition. We were in the process to understand the pathophysiology of the COVID-19. Not that we know everything already, but we have more knowledge now. We have more knowledge, and then the knowledge that we have, it allows now to to use the sedation less, also muscle relaxants, and the most important thing, pain control. No? I mean that, and there are different protocols, and essentially we're trying to individualize based on the different needs. But that was one of the key points, because of course when we think on COVID-19, we need to think as well as a patient that is probably is going to spend probably now a little bit more longer time than our regular patients, but then they need to face the post-ICU syndrome. You know, the liberation of patients from mechanical ventilation, the management of sedation, the pain control, that is a critical component in this group of patients. And as we discussed in my presentation, what is happening in the post-ICU admission when the patient go to the ward, facing all these post-ICU problems. No? I mean that just the protocols for sedation is definitely something that we need to work in our ICUs, see based on what are the medications available, because probably you want to use dexmedetomidine, you want to use propofol, you want to use fentanyl, remifentanil, but as this is a international forum, you will find out that in some countries there is no dexmedetomidine available. In some other countries there are no fentanyl. In some other countries you don't have ketamine, to give you an idea. Mean that you will need to create your protocol based on the resources available. And not only that, but also in some countries, like in Latin America, some of the medications essentially at the beginning we will have a good allocation, but through the pandemic we finalize, and the providers, they cannot get for us. No, I mean that we essentially trying to move based on what is happening at this stage and trying to adapt.
Okay, we have one more question in the chat box from Miss Sharmishta Nayi from India. I hope that I pronounced the name right. With isolation and COVID patients are suffering from isolation, with your choices, how we can remove it?
That's a very important question, because one of the most critical parts of being COVID patient in isolation is just to say it again, isolation, being without the capacity to access, to see the loved ones. No, being in ICU is already a high risk for the patients to end it with psychosis, ICU psychosis. But now being completely isolated, it makes it worse. I think so. All of us are trying to look ways as how we can keep the patients in contact with the loved ones in many ways, and then the ability to have access to the internet, the ability to have a phone and be able to connect the patients at least 2 or 3 times during the day with the loved ones, that it definitely creates an impact. We see it at the beginning. At the beginning, of course, everybody was completely isolated, but as we learn down the road how to approach, then we generate and create ways as how to keep families connected. No, because one of the most important things is we need to make sure that we kept this part of the humanity good. No? Make sure that those patients are in constant communication and with the loved ones. No, that is a critical part. Despite of that, it's still challenged, because of course admitted in an ICU with a condition that you know that it can take your life. It's a very stressful situation. No? And of course, you know that if probably it's not most of the time admissions is going to be no less than 7 days in a hospital. No? I mean, depends on how severe the COVID-19 clinical picture is. No?
Thank you, Dr. George. Ms. Nayi, I hope that we have answers you. If you have any questions, you can ask, or you can type it on the chat box.
Isolation, it is okay because where we are allowed to patient relatives, so sometimes it is comfortable for patient also, they can see the patient. But in the COVID, you know, it is totally, completely patient is isolation. There are no relatives. Even the healthcare worker movement is also very restricted. You know, without medicine and the other things, we are not allowing other people also. So that is why it is more painful for the COVID scenario. So that is what we have to struggle, how we can remove from this isolation psychosis for the each and every, maybe the frontline worker, even though the patient also.
Yeah, this is challenge. It continues to be challenge. But again, as I say, we need to be creative and see how we definitely keep the patients in contact with their families. No?
Yes. Thank you, doctor.
Thank you, Dr. George, for this informative topic, and thank you for joining us for the third day and for the second time for you. Is there any question, please? Actually, we don't have any more questions. So finally, I'm very honored to deliver the concluding remarks on the last day of the Healthcare, Nursing and Patient Safety Conference organized by UCG. I would like to thank the committee members and our staff for organizing this event and ensuring it's run so smoothly. I would like to inform all of you that the complete conference decision video will be available on YouTube and other broadcasting sources. The certification will be provided to you on April 10. UCG is organizing the 8th Emirates Healthcare Management, Nursing and Patient Safety Conference on December from 15 to 16 December 2021 in Dubai, UAE. So I hope we all meet again with a new research and innovation in the field of healthcare, nursing, and patient safety. It's been an honor to be among such accomplished individuals and to be able to present my perspective before you. Thank you and good evening or day to you. I know that all of you have had a long week and have participated actively. So I thank you all once again for your participation. We look forward to meeting you at our conferences. Thank you. And now I am passing the stage for Mr. Carr.
Thank you, Amal.
You're welcome.
Yeah, I just want to say thank you for having me, and it's been a great conference. I was unfortunately unable to see the first day due to university, but it was what I have seen, and I've been fortunate to see many presentations and to share this sort of space with so many professional people and amazing people. I'm grateful for, and the support of the UCG team as well has been amazing. And I just want to say thank you, really, and I wish you all the best. And hopefully we can all meet again.
Okay, I guess it's my turn now. From Switzerland, also from my side, thank you so much. It has been such an interesting conference. It has been such a pleasure to also be able to chair the first day and to be amongst you. Also, the UCG has done such a great job in organizing this conference. And actually, there were 38 speakers today over these 3 days. What an amazing number. And every single speech has been so uplifting and so interesting. So thank you all for your time. I guess also the digital Zoom issue has been a bit dodgy at times, but you just see also that is a side effect of the pandemic, how well we all coped with electronic devices and how quickly we adapted. It is like in the ancient days when we used to work with those projectors, then came the beamer, and now we actually all are on Zoom and MS Teams and whatever all these devices are called. So unfortunately, I have to say it would have been so lovely to actually meet all in Dubai and to have ongoing talks after the single days and socialize. And I think we heard that very much in Miss Annette's speech, how important this is. And I hope that we can connect at least over social media platforms. Please go ahead and share all the speeches on YouTube, just connect on LinkedIn and whatever platform you're using. I think that is such an important way also to stay in touch and to exchange the experiences that we all shared after this conference has come to a close. So thank you again once more. It's all that I have to say for this wonderful exchange, and have a wonderful time and stay safe wherever you are. That's from Zurich, Switzerland.
Thank you for all the organizers.
Thank you very much
I would like
for having
to
me.
thank
Been,
Amal and all the organizers.
Time. Oh, sorry.
Okay, no problem. I just want to thank you also, including thank you very, very much for all of you, for all the organizers, for Amal, for Suzanne, for Mr. Carol, for Mr. Sherifat, Madam Sherifat. It will be more pleasure if we made sure at least there will be exchange for the experience together when we meet together and sit together out of the lectures. But also it was very nice presentations. I got a lot of experience. Thank you for all the participants. Thank you for all the presenters. Thank you for the organizers. And I hope, inshallah, this pandemic to come over, and next time we can meet physically, we can exchange the experience. Thank you very much. Thank you.
Sorry about that. Thank you very much for this interesting and educative occasion. I hope we are in Dubai and we can have lovely time together in the evenings and relax before the other days of the conference. It's been nice meeting all the speakers virtually, listening to so many interesting and educative presentations, which are really, really overwhelming. I'd like to use this opportunity to thank you all, and I hope we're going to meet again soon. Thank you very, very much. So I think this is the end of the conference, and we are using this opportunity to close this conference. At the same time, we are using this opportunity to say we can share this all over on our YouTube, on our LinkedIn, Twitter, so that people can see what we have done, the interesting talks.
Hello, I have a problem with my laptop. Can you hear me?
Yes, we can.
I can hear you now, sorry.
So shall we return the problem with Ms. Anna Maria? I would like to thank all of the speakers for the 3 days for joining us on this amazing conference. Really, all the decisions were wonderful and great. We had a great conference with great speakers with an excellent, actually, experience and topic. Hope to meet all on December in Dubai, face to face, to exchange our knowledge and our experience. So thank you very much for this lovely event and hope to see you again. I would like to remind for two important points, such as the complete conference decision video will be available in YouTube and other broadcasting sources. The certification will be provided to you on April 10th. And we are organizing the 8th Emirates Healthcare Management, Nursing and Patient Safety in Dubai from 15 to 16. Hope all to meet again with the new research and innovation of healthcare, nursing and patient safety. If you have any questions or any comments, you can email us or you can text us on WhatsApp, LinkedIn, or any kind of social media. Stay safe, stay positive, and we all of us to have to control COVID-19. See you then.
To everybody.
Thank you, Suzanne.
Thank you, Sharifat. Thank you, Mr. Assam, Mr. Carr, and Laura from Spain. Thank you for all speakers.